Very good afternoon to everybody. Namaste. Welcome for the Foxy ICOG certificate course on midlife management. It will be a 3 days course, 4 to 7. Today we are starting with our first day, and I welcome all the dignitaries, Dr. Parag Binniwale sir, ICOG chair, Honorable Secretary Dr. Sarita Bhalerao madam, Dr. Ashok sir, Vice President, and Dr. Sunita Tandulkar madam, our Foxy President, Dr. Suvarna Khadilkar madam, our Honorable Secretary, General Secretary Foxy, on this platform today together, and also Dr. Ashok, Vice Chairperson of ICOG, along with President-elect, Vice Chairperson-elect, Dr. Sheila Mane madam. To start with, we'll first of all take the blessings of our Lord. So can we have the prayer, please, together? Nilima, we cannot hear the voice. So once again, thank you so much. May Lord bless this webinar with his best wishes, and may the trainees be more and more benefited, because we all know midlife is a transition.
Archana, you're muted.
Okay. Right. So namaste, and once again, welcome to our Foxy and ICOG President, Dr. Sunita Tandulkar madam, ICOG Chairperson, Dr. Parag Binniwale sir, and Foxy Secretary General, Dr. Suvarna Khadilkar ma'am. We all know that this is a transition phase of life where we all need to be well equipped to have a better midlife and menopause. I welcome Dr. Sunita Tandulkar madam, who has been always supportive to us, our Foxy President at present. Dr. Parag Binniwale sir, our Chairperson, Indian College of Obstetrics and Gynecology for this year 2025. Sir, I would like to welcome you for your words of wisdom for today. Give your blessings to the webinar.
Thank you, Dr. Archana. Good afternoon, all. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all for this month's certificate course on menopause midlife management. All of us are aware that October is a World Menopause Month, and we always take an opportunity to discuss about issues related to the midlife health. And here we try and get all the experts all across the country who are working in the field of menopause and midlife management. First of all, let me appreciate the efforts put in by our three conveners, Dr. Archana Dwivedi. Archana, thank you very much for taking this certificate course on your shoulders, along with Dr. Anju Soni and Dr. Rajendra Nagarkatti, who are all ably guided by the Secretary of ICOG, Dr. Sarita Bhalerao. And special thank you to all the coordinators who have agreed to be with us, Dr. Reshmi Banerjee, Dr. Madhumita, and Dr. Aditi. Thank you for sparing your time for this ICOG activity. A warm welcome to past president of Foxy, Dr. Pankaj Desai, who's one of the most popular teachers across the country. Thank you, sir, for being here in the ICOG program. Next 3 days is going to be a good learning experience, and I'm happy to say that there are already 400 people who are registered for this course. However, please note that attendance of all 3 days is a must, and you need to appear for the post test, which will be conducted at the end of the day. And you need to secure more than 50% mark to get the certificate and, of course, ICOG credit points. So my best wishes to the entire team for a fruitful program and happy learning to all the viewers. Thank you very much.
Thank you, Parag sir, and thank you for the blessings. I would also invite Dr. Sarita Bhalerao madam to give a few words of wisdom. Her constant support, anytime you call her, she has been always supportive to me. Over to you, ma'am.
Thank you, Archana, and I welcome, as Dr. Parag said, we welcome everybody. A big thank you to our conveners, especially Dr. Archana, who's done a lot of work for this program, and it's wonderful to see Dr. Pankaj Desai sir here and Dr. Maninder Ahuja, who are stalwarts in this field. I'm sure it's going to be very, very exciting, this whole 3-day program. So do stay with us. Thank you.
Thank you, ma'am. I think I'm not able to see Suvarna madam and Sunita madam at present, so we'll take their blessing ASAP as they joined us. So, with this inauguration and blessings with presence of Dr. Pankaj Desai sir, our ardent teacher, Dr. Maninder Ahuja madam, and all the respected people, and my previous midlife chair, Dr. Shaijas Nair, I can see him. So, all of you, welcome to this webinar. Now we'll be starting, and I would just like to introduce myself as the current Midlife Committee Chairperson, Management Committee Chairperson, Foxy. And when it comes to midlife, we all know that is a phase of transition from somewhere to nowhere for a female who's actually suffering from many of the problems. So we are here as a first-hand healthcare providers, as gynecologists who cater our patients at the first point of contact. So we need to be trained, we need to be well equipped to give them a better life ahead. So today, day one, I invite you all to join me to learn the basics of what is actually epidemiology and definitions about the menopause. And then we'll be going to the diagnosis. How do we use the AI apps nowadays available to have a better diagnosis? Premature menopause is an entity which is going to stay, and maybe we are going to see more cases off and on. The lifestyle disease, as we know, this year's theme was lifestyle medicine. So we have to discuss sleep, which is very important part of midlife disturbances in life, daily life course. NCD screening is one thing which is a mandatory thing we have to take care. There are vasomotor changes. The sexual health is suffering for the female somewhere. And most important thing is that now nobody wants to marry and get pregnant early. So there is a stage where we call fertility at midlife, where we will be discussing about in vitro fertilization after 40, pregnancy complications after 40, the new era of ovarian rejuvenation. And for all this, we have our esteemed stalwarts who will be justifying the topic as we go ahead. As the things unfold, I think this will be a very good learning evening experience for today. So with this overview, I would like to just share some instructions to all the participants about the post and the pre-test of some MCQ. There will be a question pattern which will be now displayed after this slide. You need to know that delegates of Foxy ICOG online course on midlife management, which we are conducting today. Here, the attendance for all the 3 days of the course is a compulsory point. Google link for MCQs will be sent in the chat box. Those who have attended all the 3 days course and passed with 50% mark on each day, then they'll get the certificate from ICOG. Certificates will be sent within 1 month. And please note that this online course certificate is just an acknowledgement of attendance. Practice depends on your skill and experience, which we do not certify. So we do not endorse any skills of the attendees. The videos will be put on ICOG website in due course. For the course material and equipment details, you may communicate with the course coordinators, whom we'll be displaying every day. So with this pretext, I would like to invite my day one coordinator, Dr. Reshmi Banerjee, who's also a member of Midlife Management Committee Foxy for this year and coming years as well, who was also the member of Imaging Science Committee. And she has her own areas of interest, where the most lucrative thing for me is menopause, as I'm in the midlife right now. So over to you, Reshmi, for carrying out the program from here. Thank you, everybody. I hope the webinars becomes very useful to all of us. Thank you. Rishmi, you are muted. So are we going to display the pre-test, Nilima, right now?
Yeah,
Archana, there's no pre-test. There's
Okay,
only
so we'll have
post-test
only
now.
post-test. Okay,
Yeah.
fine. So we'll go ahead.
okay. So thank you, Archana, for the warm welcome and introduction of me, and hoping to do a good job in front of all the stalwarts. So carrying the academic session forward, I invite the first chairperson today. The first chairperson is Dr. Vanna Patel, who is is the senior most practicing gynecologist in the city of Baroda in Gujarat. Dr. Vandana Patel. Then the second chairperson is Dr. Pratibha Singh, who is a senior practitioner in the city of Bhagalpur in Bihar. She's also a committee chairperson with Foxy, and she's also a senior menopause practitioner in Bhagalpur. And the third chairperson for today's session is Dr. Shubha Sethia, who is a practicing gynecologist and a menopause consultant from the city of Jaipur. So the welcome the chairpersons. I will also introduce a speaker one by one, and at the end of each session, I would invite one of the chairpersons to give their comments. The first speaker for the day is none other than our very own Dr. Maninder Ahuja ma'am, who is practicing very senior gynecologist in Faridabad and an epitome of menopause women of India, I would say, and Foxy. And we are very familiar with all her videos and pictures on Facebook. So over to Dr. Maninder Ahuja ma'am. Dr. Maninder ma'am?
Yes,
Yeah,
I'm
Dr.
Yeah,
Vandana
madam
Patel,
is going
madam
to
is
speak
here.
on epidemiology and definitions of menopause.
Reshmi chairperson, madam is here. Vandana ma'am is here.
Yeah, I welcome now all three, Dr. Vandana ma'am, but so each
Fine.
chairperson will give their comments after the speakers.
Okay.
So after Dr. Maninder Ahuja ma'am, I would
shared-
invite Dr.
I had
Vandana
shared-
Patel ma'am.
I had shared, I can't find now. Yes. No, this is wrong.
You shared, madam, previously.
I had shared, I think that was not there. Stop share. That is not there. I'll have to share again. I think.
Start my video. Once you access your camera from device.
Yes. I have to again start sharing. Now it's there?
Yes, ma'am, please.
Yes,
Slide
ma'am.
share.
Yes,
Yeah.
ma'am. Slideshow put up.
Yes. First of all, I must thank ICOG for this effort and for involving me here as ICOG faculty. Thanks to Dr. Sarita Tandulatka Suvarna, who are the Foxy representative, and then Dr. Parag Biniwale, who is a close friend but chairperson of the ICOG now. And then the Dr. Ashok, who is the vice chairperson, and Sarita Bhale Rao. Then conveners, coordinators for today, Dr. Archana, Dr. Anju Soni, and Dr. Rajinder Nagarkoti. And all the coordinators who are there, and my chairpersons, Dr. Reshmi Banerjee, Dr. Vandana Patel, Dr. Shubha Sethia. So my topic today is, am I audible?
Ma'am, you're audible, but your screen has got something else now.
Yes, ma'am, you are audible, but your screen share, the slides have something else.
It's not this one?
No.
It's
But
not
initially it came,
epidemiology?
madam, initially it came, but then it went off.
Okay, let me share again, then.
Hey, Maninder, this is the right one.
That was the right one, but they said ki no.
It's written a web page not available.
Ma'am, I am able to see the screen, ma'am.
You're able, now we can also see.
Now we can also
Baroda
see.
has some problem. No problem. Ma'am, continue.
We could see web page not seen.
Now I'll have to share again because I had stopped sharing.
It is showing as sharing only, ma'am.
Ma'am, just put it on show mode and start. It is there, but go to the first slide, please.
Oh, I am not on the share mode now.
Ma'am, we can share you.
After, no, I can't share like that. Okay, I'll have to stop it. Just give me 1 minute. I think I lost the slides now. Menopause
You
basics.
speak without
No.
slides, no problem.
I can speak. But you will be looking at my face only.
It's okay, ma'am. You can start.
Chennai AICOG entire oration was given without slides. TEC
I'm
Barnes, and
opening,
this was
open recent.
when Bhaskar Rao was alive. Slides तो हमारे assistant है, हमारे boss तो आप है.
Okay, now I'll be sharing. Okay,
Yes, ma'am.
Yes, we can see now. Yes,
you can see.
yes,
Ma'am,
yes,
we
madam.
can see.
Dr. Pankaj Desai, as you said, yes, we speak the slides are just to look at, and if you just
मैडम
listen to me,
आपको
that
देख के ही मजा आ जाता है.
yeah. So
I always love to tease you. Go
yes,
ahead.
the menopause, all of you know, is a retrospective diagnosis. You have to go back 12 months of amenorrhea. Somebody is speaking, and if the problems occur after 12 months of amenorrhea, if the bleeding occurs, that is abnormal. Otherwise, for 12 months of amenorrhea, it's a stage of hypoestrogenism. Now, first, let's look into the magnitude of the problem, why we want to know about the menopause. Now, magnitude, we are living in an aging population. The current population of the India is, I'll just reduce the slide, yes, 1.46 billion, and it is expected to go up to 1.67 billion by 2050. And Indian life expectancy is also increasing from the previous 40.4 years in 1950 to now it has extended almost to 74 years. So look at that problem. Now, menopausal women in India are also increasing with that population. So 46 million women above the age of 42 to 49 were in 2024, and they are expected to reach to 57 million. Same way, the women above 40 years of age were in 2011 96 billion, and 2024 they are by 270 million by 2050 will be there. And what is about the average age of menopause? That is 46.6 years in India. So it is lower than that of Caucasians. About 4 to 5 years difference is there. So 46.6 plus minus 46 years is the age of menopause in India. Life expectancy is increasing globally. So 26% of the women and girls globally above the age of 50 were there in 2020. And there are currently over 1 billion women worldwide who are menopausal or postmenopausal. So the population of menopausal women is expected to grow at a very fast speed, and we have to look after into the health of those women who are entering into the menopause and who are living beyond that age also, that we are increasing the healthcare facilities, or if we start diagnosing early. So WHO also defined the menopause as continuum of life stage. That is very important. It's not a it's a chronological aging. It's a dynamic period, like puberty and menopause both are dynamic periods which lead on to the growth later or the senescence in cases of menopause. So menopause is caused by loss of ovarian follicular function and a decline in circulating blood estrogen levels. And clinical implications of age of India is there, that it leads on to early age of menopause in India is going to lead on to more women with the chronic health disorders a decade earlier than the Caucasian women, because menopause transition is one risk factor where the adverse metabolic effects occur in the women. So earlier onset is because of the low BMI, maybe high central adiposity, genetic predisposition, lifestyle factor, low disease awareness. But the fact is that our age of menopause is earlier. So that leads on lots of challenges are there, psychosomatic symptoms which are there on the menopause rating scale. High prevalence of diabetes, metabolic syndrome, CVD, thyroid diseases, osteoporosis, cancers, which are already high in India, incidence is high. So that increased incidence of those problems is there after the menopause transition. We have to redefine our premature or early menopause or delayed menopause, which should be early menopause should be about between the age of premature menopause, that is 40 years to 60 years, but the Caucasian, it is later on. So early onset of declining fertility is there, early stage of cancers is also set in because of the early age of menopause in our country. So there are some definitions which were there, but which were not sufficient to define the menopause. So that's why later on the straw classification came. So definition was the premenopause or reproductive period, which is before menopause. Perimenopause, menopause transition, something which start 3 to 8 years before menopause, and disturbed menstrual cycle, endocrine changes are occurring there, and state of hypoestrogenism, which is leading on to all those symptoms all over the body in the women. Post-menopause is the span of life dating from final menstrual period, regardless of whether menopause was spontaneous or iatrogenic. So premature menopause, wherever the Dr. Pankaj Desai will be talking, is that traditionally it should be 2 standard deviation below the estimated age of reference population. For the world, it is Caucasian, it is 40 years. For years, for us, perhaps it should be 38 years, but because we have not done any population study, so we are still taking it at 40 years of age only. Early menopause is there, the span between the premature ovarian insufficiency or premature menopause and the accepted typical age of in that country or population. So supposing our age of menopause is 46, 47 years, and the time period between 40 and 47 years, if the menopause occurs during that period, so that is early menopause. Delayed menopause, if it occurs beyond the expected date of menopause, so it can, because of the prolonged exposure to the estrogens, it can also cause problems of cancers, uterine cancer and other cancers also. Induced menopause, when we are doing iatrogenic, most of the time when we are doing bilateral oophorectomy, iatrogenic ablation, which are not required, or sometimes when they are required because of the cancers or anything, so then it is the induced menopause. Temporary menopause is not the terminology which should be used, because the menopause is permanent. It cannot be temporary. That is just amenorrhea, temporary can be there. So postmenopausal bleeding, if it does not occur for 12 months of amenorrhea, then any bleeding occurring after that is important. And even if it occurs after 6 months, then also we should investigate. Why I have taken this symptom, first of all, is because this is the only symptom when the patients are coming to us. They don't even know, most of the patients don't even know that when they are having other psychosomatic symptoms, sleep disorder, mood disorder, they should come to us and the treatment is available. So this is the only problem when they feel, or the genitourinary syndrome of menopause. So because the puberty and menopausal transition are both dynamic periods, so we have a classification system, staging system for puberty, Marshall-Tanner stages for puberty, but we don't have any staging for the menopausal itself. So that's why the staging of Bayram-Eccles area, staging of STAR 1 and then STAR 10 were introduced later on to define all these definitions which we were talking about now. So now the female reproductive axis is essentially composed of hypothalamic pituitary ovarian axis and Mullerian-derived structures such as the uterus. And then they lead on to the non-functional state of menopause much earlier than the other organ system. That is very important. So that means when the women are entering menopause, they can be completely healthy women also. So we cannot just make them, I label them that they are post-menopause, so they need the treatment. It's not like that. So that is why the guidelines also have changed lately, where we are talking about the lifestyle medicine as the management of menopause. And it's not always menopause hormone therapy. That is one thing I have to clarify with all of you, that it is not always the menopause hormone therapy which is the solution. Reproductive aging consists of steady loss of oocytes from atresia and ovulation, which is variable in different women, either endowed with a highly variable number of oocytes or lose them at a high variable rate. That is why variable age of menopause is there, 42 to 58 years. The response of the women to menopause is also variable. So it has to be completely individualized, because the women may come to you with symptoms, without symptoms. They may come to you with comorbidities, without comorbidities, or just the risk of comorbidity, or just the genetic factors might be important. So that is why we have to look into the menopause transition very closely and identify the women, what the care they needed and follow them up so that the compliance is there. That is very, very important in this case. So we need staging because we have to guide them about the healthy aging when they should start lifestyle modification if they have not started earlier. And for the fertility, contraceptive needs healthcare decision, but most of all, you need it for research also when you have to compare the data. So when will you compare the data? When proper staging of the menopausal women has been done, then later on when there is ovarian versus somatic aging also. So you also have to identify that these started with the somatic aging or these symptoms started reproductive history, lifestyle, and environmental factors, which the women were leading already, along with then the menopause transition. So that is very important. And personal or professional lives, what type of life they were leading at that time previously, and what they are leading now. So they are also interrelated thing. Uh, Therefore, perimenopausal care plays an important role in the promotion of healthy aging and quality of life because that was once considered a time of opportunity. But I think I'll just give a passing reference to studies which are coming up where they say that maybe menopausal care starts much earlier than the menopause transition itself. So this is how the hormonal changes are taking a FSH, LH rise, they become, and the estradiol, they comes down, and estrogen, that becomes the dominant hormone because of the peripheral conversion. So these are the hormonal changes which are occurring, and physiological changes, consequences of changes in the ovaries and the hypothalamus. So the changes in the hypothalamus, they cause increased FSH, LH, norepinephrine, dopamine, prostaglandin, and all these are going to cause insomnia, mood swing, hot flushes, depression, and then ovary changes will lead on to the, because the estrogen receptors are present all over the body, and the estrogens are acting through those receptors only, and the response of different persons to those receptors to the drugs is also different. So bone, cardiovascular system, vagina, breast, uterus, osteoporosis, atherosclerosis, atrophy of the body, skin, collagen tissue, everything is occurring along with the weight gain, which is there, the mean change in the. So from pre-menopause to menopause, dominant hormone from the ovaries 95%, and from the periphery 5% before menopause. But after menopause, it's become the FSH is elevated, inhibin, AMH decrease, and main circulating hormone becomes the estrogen, which is from the peripheral conversion. Now, one important thing which you should keep in mind is when the hormones are coming down, estrogen, the reduction in estrogen initially is 35%, but in reduction in progesterone is also there, which is 75% in the between the age group of 35-50 years. So when the women come to you with abnormal uterine bleeding, at this period, they can just be prescribed progesterone only, and they will be improving with that. So staging of menopause was ancillary roughly 2 years before. Would I be given the 2 minutes which I wasted? Okay. So first stage, vasomotor instability, prevent and treat. 2A,
Sorry to
gain.
interrupt you, ma'am. Your time is up. Yeah, 1 minute to
Time
go.
is up, or I should be
Yeah.
given the 2 minutes I wasted in.
Yeah, sure. Yeah.
Just 2 minutes. So these are the symptoms: psychological, skin, collagen, fertility, vasomotor symptoms, vaginal atrophy, dyspareunia, osteoporosis, atherosclerosis, and perimenopause I have defined here. So this was the stock classification. Stock classification 1 to 2 change came, that from the -3 stage was divided into late and early. First two stages are reproductive aging. It was the reproductive aging. This is the final menstrual period. -2 and 1 are before that. In the straw 10, what they have done is they have divided -3 into 3B and 3A. And 3A, you start with the FSH changes, and 2A, -2 and 1 are the menopause transition, where the cycle change of more than 7 days occurs, less or more. And in the stage late transition, more than 60 days are there, and FSH levels start increasing, and they get almost stable increase in the late, early menopause, or even the late menopause, and sometimes in very late menopause also fluctuations are occurring. So this is the three stages of reproductive aging, where 3A subtle changes in menstrual cycle start, and early menopause transition, so 7 days, and then 60 days variations in the menstrual cycle is there. That is the change in the stage star 10, because then you can diagnose when the women come for those variation for a 10 months also, then you can diagnose that this woman is now passing through menopause transition. What are symptoms she's having is because of this. And then if we do FSH because of the infertility, not for the diagnosis of menopause, then you can get. So early post-menopause is +1 be a 3. So that just makes the final period and the stabilization of FSH which is occurring. And these symptoms 1A and 1B are for 1 year each, and the entire stage 3 is 5 to 8 years, 6 years. Late menopause goes on from the stage 2 to still had not been defined at what time we should be calling it complete senescence, a part of the postmenopausal. So when we cannot use is cigarette smoking, extremes of body weight, heavy exercise, chronic menstrual irregularity, prior hysterectomy, abnormal uterine anatomy, abnormal ovarian anatomy, patient treated for cancer. In them, we cannot use the staging system, and staging helps in early diagnosis of menopause transition, and we can make the people aware. So WHO also considered that social, psychological, and physical health support during the menopause transition is required, and it is a lifetime course which should be started earlier, and that has been now emphasized by the 2023 white paper on menopause adverse pregnancy outcome. They lead on to the metabolic changes during the menopausal midlife age, so they should be started early. Then 2025 theme of International Menopause Society is lifestyle modification as management strategy, and menopause hormone therapy is advisable, which we'll be looking into the all those lectures later on, only when indicated. So it's only when indicated, otherwise first line treatment if the patient does not have comorbidities, even for comorbidity should be lifestyle, that is the weight, diet, sleep, no substance use, interpersonal relationship, and relaxation exercises. And then we have to look into women in our workplace, because they are making 50% of the force is because of the women, and transgender males and females should also be looking, because they are also going through the menopause, and we have to look into their changes and this. So this is not the final word. It is recognized. This is a work in progress. I request all of you to have more and more research at your own center, in your own hospital, so that we can have our own data collection. So thank you very much for the listening, and thank you very much for being with me because of the technical hitch. Sorry for that, and sorry for the delay.
Thank you, Maninder ma'am, for that awesome presentation. And I would now invite Dr. Vandana Patel to give her comments in a couple of minutes on this talk.
I want to stop sharing. I'm stop sharing.
I hope I'm audible, Reshmi.
Yes, Vandana ma'am, you're
Okay,
audible.
so it was so nice to listen to Madam. And I remember the past when she had come to Baroda and had talked to us in our conferences and CMEs. So I have to really congratulate her for a nice talk. Only one thing I would like to comment on is that I think it's the experience which all of us go through with women who are menopausal, that they are repeatedly being so much bothered with urinary infections and vaginal infections. They are itching, burning, and irritation. And this is something which has been bothering all of gynecologists in treating these ladies who are old. And I really pity them, because sometimes they're not able to open out to their families, and they keep coming and crying in front of us. So they are the patients who really need our help a lot.
Thank you, Vandana ma'am.
Dr. Vandana, those I think problems will be taken on in the later sessions only.
Yeah,
So
tomorrow is the day we'll tackle this.
because
so
of
let us go further.
So now moving on with the academic session, I would like to invite the next speaker, Dr. Shaijus from Kannur, who is the immediate past chairperson of this midlife committee of Foxy, and he is well known and speaker for most of the country. And now over to Shaijas for his presentation.
Thank you. Thank you so much. Shall I share the screen?
Yes, please.
Yeah. I hope my slides are visible and I'm audible.
Yes,
Yes,
yes.
yes. You
Yes,
can see
yes,
the robot
yes.
dancing.
Yeah.
Yeah, that is just to check how good your network is. If you can see that there is a wavy motion, that means you are in a very, very good network.
How good
Okay.
our
And you
eyesight
are in
is,
the
puzzle people. Go ahead.
Yeah. Thank you. So first of all, a big thank you for this opportunity. Thank you to the office bearers of Foxy, Dr. Sunita Madam, as well as Dr. Suvarna, as well as the chairperson of ICOG, dear Parag sir, the chairperson-elect Dr. Sheila Mani, the vice chairperson Dr. Ashok Kumar, as well as the secretary Dr. Sarita. Regards to the conveners, Dr. Archana, who's heading the Midlife Committee now, Dr. Anju, and as well as our past chair, Dr. Rajendra Nagarkatti, sir, as well as to the coordinators, Dr. Reshmi, Dr. Madhumita, as well as Dr. Aditi. A very, very interesting topic in a way, because menopause is something which actually represents the older generation, and artificial intelligence is something that actually represents the newer generation. So we are trying to actually look at this topic and try to see how a new generation tool can be effectively used to manage a problem that is related to a relatively older generation. So that is what diagnosis of menopause with the use of artificial intelligence is going to tell you over the next 10 to 15 minutes. Now, to get started, menopause is a phase where you're searching in search of that fan, right? Too much of hot flushes and something you really need to do to keep yourself cool. It's a significant transition in a woman's life. It brings about a multitude of changes, both physiological as well as psychological, due to the natural decline in ovarian function. So effectively managing menopause would necessitate a very personalized approach that would cater to the need of the individual woman. In recent times, AI has emerged as a very significant tool in healthcare, offering promising solutions both to the patients as well as to the healthcare professionals. And that is what we would be looking at. Now, the first question that would naturally come to our mind is, why should AI be even thought of in menopause? I hope we understand that we are living in a time where we are stuck with chat GPTs and various other AI apps. Most probably, the most reliable companion for people of any age, especially the elderly woman, seems to be something related to AI. So they ask ChatGPT for their solutions. They share their problems. ChatGPT will actually console them. Okay, will make them more alert if there is a health-related problem. So we are living in such an era. So why not make use of that particular aspect of the new technology and help manage menopause a little bit more better? There are very specific reasons why menopausal health care is lacking, or it's being extensively used in a country like India. One is, most women still don't talk about their menopausal symptoms. Many gynecologists, unfortunately, are not still confident in guiding our women and maybe having enough confidence in prescribing a menopausal hormone therapy. Even those gynecs who know about menopausal management are unable to spend enough time with their patient because of the heavy and tough work schedule. Even when we start treating menopausal symptoms, most women don't come for a follow-up at all. Even if they do manage to come back, they have a lot of difficulty in recollecting what has actually happened over the last few weeks. So these are definite lacunae that is there in the management of menopausal women in a vast country like India. That is why we need to look at AI-mediated applications and see how we can use that in menopause management. It can very well be used in risk prediction and prevention. We'll definitely look about the good things first before we actually talk about a few hazards and few things that we need to be taken care of. So risk prediction and prevention. AI algorithms have actually the capability to actually go through extensive data sets so that women with heightened risk of menopause related complications can actually be found out well. And those complications include osteoporosis, cardiovascular diseases, and cognitive decline. By amalgamating clinical data, genetic data, as well as lifestyle data, artificial intelligence models can actually furnish personalized risk assessments and thereby also suggest the preventive strategies. There is a study which was conducted by Wu et al. In the year 2020, which actually showcased the utilization of machine learning algorithms to prognosticate a woman's risk of osteoporotic fractures, thereby enabling an early intervention to mitigate bone health related risk. It can also be used for symptom management. AI-powered virtual assistants and chatbots. Chatbots are zones, are programs which will do something like a human conversation. And they are invaluable resources for women. At a time when elderly women don't have anybody to talk to, if we have a well-enabled AI assistant, which is virtual as we all know, but can really make a big difference in managing these women and their menopausal symptoms. It furnishes personalized support and information pertaining to menopausal symptoms. So if somebody asks, what is a hot flash? It will clearly explain it to you so that the woman can actually understand to an extent whether what she's suffering from is a hot flash or not. These AI entities aid women in making informed decisions and also regarding treatment options as well as lifestyle modifications. AI can analyze vast amounts of data from individual health record. There are wearable devices, just like a fitness band, which will monitor a lot of things. There are self-reported symptoms which the patient can actually enter into an AI algorithm, and that can actually help them to provide personalized recommendations for managing very specific menopausal symptoms. So every data entered by a patient becomes a part of the data set, and from that database that can in turn help the management of yet another patient who's logging into that AI algorithm. For example, AI-powered system can actually track a woman's sleep patterns. It can actually track her mood fluctuations. It can actually track her hot flash frequency and thereby suggest personalized interventions. As I told, many women have a lot of trouble in recollecting this when they actually go and meet a doctor a month later. Now, these kind of devices which can actually track it can actually help and make it relatively less error prone. Interventions are in the form of lifestyle changes, dietary adjustments, or hormonal therapy, which the AI algorithm would suggest. There's a kind of a robot, which is called the Menobot, which basically exemplifies this concept of employing natural language processing to dispense a tailored advice on symptom management, about hormone therapy, about what alternative treatments are available, all based on individual preferences as well as medical history. The other area where it can seriously help is in treatment optimization. AI algorithms have the capacity to scrutinize treatment response in diverse patient populations. Because you understand, if you prescribe somebody a hormone therapy, they're supposed to come back to you a month later to actually look at the compliance. They are expected to look at the side effects. They're actually expected to come back to you after 3 months so that we can look at the response of hormone therapy, whether it's actually making a difference or not. Many a times, in close to almost 60 to 70% of patients, this regular follow-ups do not happen. So if we have a way to actually get data from them by them sitting at home, I think it will go a long way in optimizing treatment. So continuous monitoring, feedback mechanisms by AI-driven systems, and that will actually help to adapt their treatment plans in real time, and thereby you can ensure an optimal outcome. It was Johnson et al. In 2019 who conducted a study demonstrating the use of AI algorithms to personalize hormone therapy dosages based on individual symptoms, genetic factors, and treatment responses. That means somebody is actually feeling very comfortable, okay, in a treatment. You can probably think of continuing that at the same dosage. Another person who's actually not getting that initial response, you can actually think of upgrading the dosage, all using an AI algorithm, okay? So that is probably the beauty of it. The other aspect where it can really make a difference is in the health monitoring and early detection. AI algorithms can actually monitor a woman's health parameters and detect very subtle signs of health risk associated with menopause. It could be something like bone density loss. It could also be cardiovascular diseases. By identifying these risks early on, healthcare providers can actively intervene and maybe prevent or mitigate potential complications. The very important concept that is evolving is the term called precision medicine. So AI-driven precision medicine approaches will tailor menopausal treatments to an individual based on her genetic, hormonal, and lifestyle factors, optimizing efficacy while minimizing the side effects. By analyzing large-scale data, AI algorithms can identify some biomarkers, maybe like AMH, FSH levels, E2 levels, and it can all help in titrating the dosage of the drug and look at the response of the treatment on their menopausal symptoms, and thereby you can tailor make it for that particular individual. This will also enable healthcare providers to keep track of it and prescribe personalized interventions for that particular lady, rather than she reading something on the net, which will be a generalized advice, which might not be the one that is suited for her. So most of these people who attempt to be Google doctors, no? Now, the major problem with searching for a Google and finding out a solution would be that it's a generalized opinion and you don't get a customized approach. And this, with their own data, you can actually make it precision medicine. So the benefits of AI for patients and healthcare professionals would include: one is personalized care, as we have already mentioned. One is efficient resource allocation. You don't have to actually, for a clinician, you don't have to sit with them for hours together to find out how good their symptoms are improving, whether there are any side effects or not. Every data will be entered by the patient. So you will take that AI tool and will just cross-check whether whatever they are telling, whatever they are recollecting is right or wrong. The other would be knowledge enhancement, so every patient who's actually using an AI algorithm would be contributing to the data, and that can seriously help in a good shared decision making and improving health literacy. Research and development, it can definitely accelerate the pace of medical research because of a whole lot of data that is actually coming into the picture. In the context of menopause, AI can actually help researchers better understand the underlying mechanisms of menopausal symptoms. You can look at the triggering factors for that particular lady. It can actually help them develop novel treatments and identify factors that influence individual variation in symptom severity. That will be something that will be very useful. AI has been very well proven technique as far as mental health support is concerned. Okay. Even outside the context of menopause, it is being used now. Okay. Now here in menopause also, because it has got a significant impact on mental health too, you can actually look at symptoms like anxiety, depression, cognitive changes. Patient can enter that data and you can read it from the AI algorithm and can make a personalized decision. So AI-powered mental health applications can provide women with evidence-based interventions such as CBT and mindful exercises. Continuous monitoring and feedback with definite wearable devices are a big advantage of an AI algorithm. You can measure heart rate variability, skin temperature, activity levels, providing real-time feedback to women about their health status. All are big advantages factors, which will actually ensure that there is early intervention and adjustment of the management strategies. Now, what are the challenges with AI and what is there for the future? Okay. One very important thing that we're always worried about is data privacy. So AI algorithms will have to get into a zone where the data that is entered by a patient is used only for a research purpose and otherwise does not get leaked out otherwise. Its integration into clinical practice is a challenge, and we probably will have to go through this path so that we become experts in integrating that into clinical practice. Even AI algorithms will have to evolve a little bit more. I'm just finishing in a minute, okay? Long-term efficacy and safety is something which we will have to look at. So need to ensure privacy, need to find out the best ways in which we can integrate that data into clinical practice, and we will also need to work on long-term efficacy as well as safety. Now, two important things before I finish would be that there are a lot of our own people who are creating a lot of apps and they are freely available on the internet. This is by Dr. Hepzibah. This is an app called Midlife and Beyond, which will actually do a lot of things that I've already mentioned. Okay. And this is something which you can look at. And a very well-written article, which I also went through from one end to the other end, published in 2024 July in the Journal of Midlife Health. It is written by our own Dr. Ruchika as well as Dr. Atul Munshi on revolutionizing menopause management, harnessing the potential of artificial intelligence. This is a must-read article. I recommend all of the listeners to actually go through this whenever you get time. So on that note, I end my talk with some take-home messages. AI holds immense promise in revolutionizing menopause management by furnishing personalized, efficient, and evidence-based solutions for both patients as well as healthcare professionals. By harnessing the power of AI, we can elevate the quality of care, optimize treatment outcomes, and empower our women to navigate the menopausal transition with a lot more confidence and resilience. In summary, AI can definitely provide accessible support to women navigating this life transition. And every year you go through using AI in finding out a solution, I think you are unknowingly gathering more data, which can be probably be used for research purposes, as Dr. Maninda Ahuja was talking about in the last talk. So thank you so much on that note. It's been a pleasure to be here. I hope there is a lot more use of AI in offering our women with customized care to manage their menopausal symptoms. Thank you so much.
Thank you. Thank you, Shaijas. I know when I thought of AI, I could only think about you, and very well justified topic. So before we have the chairperson's comment, I would like to welcome our Secretary General, Dr. Suvarna Khadilkar ma'am, who has joined for her words of wisdom and blessings for this webinar. Certificate course. Ma'am, please.
Thank you, Archana. Good afternoon, everyone. What an enlightening talk. Shaijas, I listened to your talk because we old timers are quite intrigued with all the new apps that you have been mentioning. I have also read Richika's article on AI in our journal. And I congratulate Archana and, Anju and Rajendra Nagarkati, along with the main driving force, our president, Dr. Sunita Tandulwarkar, Dr. Parag Biniwale, and Dr. Sarita Bhalera, who are the chair and the secretary of ICOG, for taking up this midlife health in the middle of the month of October, where we always celebrate month-long various activities that we conduct for midlife women. 18th October is our World Menopause Day, which we have all actually have been every year we have been celebrating. And this topic, all of you know, is very close to my heart, and something which I started in year 2000, organizing one CME on menopause, has really made me more and more interested over the years. And I have really enjoyed working in the field of midlife health throughout. And I can see so many of you. I can see our seniors like Dr. Pankaj Desai. I can see Maninder, who is already here. She's the queen of midlife health, I can say. And I congratulate her for taking over as the president of SAPOMS. Maninder, you have made us proud. And I also see so many other, I see Reshmi, I see Dr. Anand, Dr. Vandana, and others. I can't see Vai, Pratibha. They all are, and Madhumita has been coordinating with me. Dr. Sushma Bakshi ma'am, I think she is one of the very senior person who has been working with me in the Indian Menopause Society as well as in FOXY. And I really congratulate the whole team for putting up a wonderful 3-day course. What I see is you have brought together all stalwarts who are working in the field of midlife health. And the day 1, day 2, and day 3 programs, it's a very, very vast and detailed and truly a training program in the, it's not just a 1-day or half-day CME in this, but a 3-day in-depth discussion in the midlife health. I'm very happy to have joined this program, and I congratulate and I wish you all the best for this program. Archana, you are doing a great job as a chair of midlife committee. So was Shaijas, who was earlier of the same this thing. I can see Parag. Wow, I thought you are not there. Parag, congratulations. You have been doing great work in ICOG. I think all your, I quietly listen to all the talks. You bring together so many good, topics, so many good stalwarts who are speaking in their expert fields. So I wish you all the best. Thank you so much for inviting me here.
Thank you, Suvarna ma'am. Indeed, a blessing and encouragement from you. Coming from you is a real boost to all of us. So not standing in between the program. Over to you, Reshmi. Chairperson's note. I think Dr. Kanchan Sharma madam is here. And Dr.
Yeah.
Pratibha Singh is
Yeah,
here.
so I would like to
Yeah, sir.
invite Dr. Pratibha Singh to come to give her expert comments on this talk.
Thank
And
you.
Dr. Kanchan Sharma for the next one, I'll invite you.
Thank you, Dr. Rashmi. So good evening, everyone. And Dr. Shajash, it was very informative talk. As we all know, traditionally, menopause has been diagnosed on the basis of clinical symptoms and hormonal tests. But now today, this artificial intelligence has revolutionized the process. And you have very rightly pointed that AI-powered applications can become reliable apps. You can track and monitor symptoms, hormonal patterns, lifestyle data, voice biomarkers, and everything. So many markers are also available which can predict menopausal transitions. So by combining clinical expertise with AI-driven analytics, these tools can hold to enhance early detection, improve patient counseling, and also it can facilitate individualized care, which is very important now. So very rightly you have told about the precision medicine, then for the treatment management, tailor-made management, and also it can be used for research work. So a lot of benefits, but then there are also challenges along with this, because with every new technology, there is some challenges we have to face. So we need to work on safety also. So it was again very informative and a very apt talk. And for this, I would like to thank the organizers, especially Dr. Archana, Dr. Anju ma'am, Dr. Rajendra sir, for opportunity. And my regards to our president, Dr. Sunita Tendulkar madam, Secretary General, Dr. Suvarna madam, then ICOG chair, Dr. Parag Binewala, Dr. Sarita Bhalerao ma'am, and other office bearers. So thank you so much for including me in this. Thank you. Over to Dr. Reshmi. Thank you, Reshmi.
Thank you, Pratima ma'am, for that for your comments. Now over to the next speaker for the evening. Can I have? Yeah, he's Dr. The next speaker for the evening is Dr. Pankaj Desai, who needs no introduction. Especially, he's a very senior speaker and a teacher to our local to our Baroda Medical College, and teacher's teacher, I would say, and a student's teacher also. And he's a great accommodation teacher, scientific researcher, and inspiring public speaker. And he has got a very enlightening YouTube channel, and which he keeps on regularly updating. And I often go through these lectures. Now over to sir for his talk on premature menopause.
I just would like to share the screen and see the full this presentation view.
As a slideshow, you'll have to go for slideshow.
Yes, and somehow I don't know
the
why.
slideshow is at the right hand bottom near the
Just
Zoom.
a second, Just a second. Okay. Okay, can you see the slides? Can you see
Yes, sir.
Lord Buddha?
Yes, sir. We can see Lord Buddha with the lotus.
You become philosophers when you handle menopause. Let us start with prayer as usual. My convention for more than 800 years, 800 lectures. May I become at all times a ship for those with oceans to cross, a sanctuary for those in danger, a lamp for those without light, and a servant to all in need. Thank you very much for inviting me. I am honestly thankful to every one of you. Please, if I don't take your names, don't feel bad. I know many times in Foxy, people sit here only for names. Please, I am very much thankful to you. Please pardon me. Especially to Archana. I got only 15 minutes there and cover lots of ground. Archana always gives me tough topic. This is not a tough topic, but it is a very current and very long topic. Thank you, and Reshmi, to thank you also for coordinating well. This is a premature menopause. She knows what she is. Actually, this is what has happened. And that is what we are going to discuss this in the next 15 minutes. How often we see this? You may think that it is unusual for me to take it as a theoretical lecture, but I had no other way. I tried everything, but this only comes out the best way. Affects 1% of women. So it is not so uncommon, please. premature menopause is seen in 10 to 28% or 30% of women with primary amenorrhea and 4 to 18% of secondary amenorrhea. So next time you get them in your clinic, be alert. They may be developing a premature menopause. How do you identify them? Not very difficult. A woman under the age of 40 presenting with history of primary or secondary amenorrhea, vasomotor disturbances or other signs of estrogen deficiency, and confirmed by elevated level of follicle stimulating hormone. I was asked this question, I have seen this question being asked by Dr. Chelappan, that how can you make out that there is a transition? The periods will still go on, they will not go in amenorrhea. He has asked for general menopause, but some of these symptoms and signs will start developing, Chelappan. And the first one them will be vaginal dryness. At the same time, the periods will become lighter or they will become sparse. And if this is occurring before 40, she is developing a premature menopause. Why is it dangerous? If it is not so dangerous afterwards, then why is it dangerous? Yes, these AI men will tell that don't be so afraid of AI. I use AI profusely every day and I'm 60 plus. So all of you also will be very comfortable once you start using, and then you become its slaves probably, or its friends, not slaves. Women are at a higher risk of neurological diseases compared to other menopausal women, psychosexual dysfunction, mood disorders, osteoporosis, ischemic heart disease, infertility, and premature death. Premature death. Menopause doesn't kill you. It is just a passing phase. Premature menopause can kill you. Let us go deep inside and see why this is happening. Only one slide. There is lack of gonadotropin receptors. In the underlying, that is the underlying cause. Basically, what I would like to tell you is that these receptors are either abolished over a period of time because of reasons I'll tell you, or they are low to begin with. And therefore, they enter menopause earlier. Some causes are explainable, most are not. And what are those? The genetic mischief is explainable. Turner's, commonest, 45XO. Taught since undergraduate days. Pure gonadal dysgenesis. Our familial T18 and T13. T18, T13, T21 are OBGYN's friends. Those who handle pregnancy like me. Ovarian dysgenesis. Sex chromosome anomalies. As regards the metabolic rogues, I will use these words, the rogues and all, because premature menopause is not something good to have. 17-alpha hydroxylase deficiency, galactosemia, and myotonic dystrophy. Autoimmune POFs, like thyroid, they are associated with, autoimmune POF is associated with thyroid disorders, mumps, hyperparathyroidism, and Addison's disease. Now, if we take an ovarian biopsy of these women, then what will you find is there is infiltration of plasma cells, and these follicles are present. There are lots of studded with lymphocytes. That means in these women, this was autoimmune. And many times this autoimmune condition doesn't present only with POF or these conditions. There are some other friends. It is not alone. And what are these? The diabetes mellitus goes with it. At 38, 36, 32, not expected to be. Nowadays, yes, you are seeing them, but not expected in this mother. Myasthenia gravis. I have seen a patient of myasthenia gravis associated with POF, rheumatoid arthritis, and SLE. Where everything is there, infections will be there. And can infections produce POF? Yes, they can. Mumps is the commonest. However, pelvic tuberculosis. Yesterday I handled an endoscopy in a pelvic tuberculosis. Coming events cast their shadows. Please, pelvic tuberculosis can be found in 3% of these cases. It results in intrauterine synecdoche with endometrial destruction and not ovarian failure. So technically, this is not POF, though she will enter into secondary amenorrhea. Smoking. Seen quite frequently nowadays amongst women. Many times we have to ask also, and good that we ask. And what we find, there is a dose-related effect of smoking on age of menopause. More you smoke, earlier you enter menopause. The effect of smoking is caused through the polycyclic hydrocarbons which are contained in the smoke and not not the other agents which are affecting the lungs. No. Which is very silent? Who? We are causing premature menopause. Iatrogenic, radiation and chemotherapy. Reversible in the ovary may resume ovulation and menstruation after a year of amenorrhea, after the chemotherapy is over. The chemotherapeutic agents which are notorious to cause this are alkylating agents, methotrexate, 6-mercaptopurine, actinomycin and adriamycin. This is because I have suddenly noticed that this is actually a teaching session, and therefore there are more than 200 people. I see such heavy attendance in webinars every month when I teach some other countries. Last month I was teaching Middle East countries a few weeks before, and the attendance was more than 1,000. So this happens when there is teaching, and therefore we have to mention these agents to complete the list. Ovarian failure following hysterectomy is seen in 15 to 50%. This is caused by impairment of ovarian vascular supply even if you don't remove the ovaries. And loss of some important endocrine contribution by the uterus to the ovaries. This in itself is a full lecture for an academician like me. Yeah, day before yesterday, a TLH we were doing, 46 years young lady, a totally normal ovaries. And the team discussed during surgery, shall we remove the ovaries? I said no. Ovaries are looking fine, please don't touch. The benevolent knife, the prophylactic oophorectomy, that is where I'm bringing in, over time has doubled between 1965 and 1990. Bilateral oophorectomy is carried out to prevent ovarian cancers, so be it. Prolonged GnRH therapy, which can cause this suppression, other chemotherapeutic agents, particularly alkylating agents. Clinical features, vasomotor symptoms. Amongst premature menopause, these are loudest. Vaginal symptoms, dryness and dyspareunia. Urinary symptoms like frequency, urgency, incontinence, atrophic cystitis, sexual dysfunction, and sleep disturbance. In that transition, what you were asking, Chelappan, sleep disturbance might come first with sparse periods in young women, and that would give you a sign that she is entering in this. Headache, depression, anxiety, irritability, skin atrophy, joint pains, cancer phobia, pseudocyesis, and lack of concentration. Headache, fine. Husband is a headache, sometimes they tell. That's fine. Sleep disturbances, it might be told for me also, no problem. Also, sleep disturbances I have already mentioned. Along with it, severe hot flushes, waking them up, presenting with cognitive affective disorders, resulting in sleep deprivation. What will you see when you put this speculum inside? Loss of vaginal mugi, very striking. Shortening in a young girl, 28, 30 years. Why should there be a narrowing of the vagina? Why is the mucosal elasticity reduced and that moisture which you find is not seen? Why is this happening? At 30, at 28, she is entering into a premature menopause. This is a typical case which may present in premature menopause, and you know what it is, urethral carbuncle, not carbuncle, please. Urogenital atrophy and urogenital diaphragm weakness, dysuria, urethral discomfort, and stress incontinence. Lab support. FSH level more than 40. Please remember, it is going to be asked in your MCQs also. I am a bad examiner, but a good teacher. I give out questions. This is going to be asked in your multiple choice questions. FSH level more than 40. All others are already known to you. We are not going into details because I don't know how this time has gone away. I have got only 2 minutes and 52 seconds left. I think people expected it to be a boring lecture. I understand. Consequences are already covered. I have covered them in one line, but something intriguing you may see in premature ovarian failure, and that is she enters in so-called POF. Then there is a possibility that a spontaneous resumption of menstrual cycles can occur. In some cases, though it is not a norm, even it can lead to a spontaneous pregnancy, and periods may return after therapies like chemotherapy or radiation. I have already given you the example, but the chances decrease significantly the longer a person goes on without menstruating. We used to differentiate between resistant ovarian syndrome and premature ovarian failure. These were actually cases of ROS. Nowadays, that terminology is not much used. We come to the last part, management, 1 minute 56 seconds left. Management of premature menopause. This timing has prematurely been usurped. I have spoken more than 800 times, I know. There is something mischief, the timer requires to be worked on. Management. If desire cause of pregnancy, Dr. Sushma Ben is going to teach you. My problem is solved. With induction of ovulation outside donation, it is possible. It is now possible to restore follicular maturation, ovulation, and menstruation with treatment of identified cause of premature menopause. Just before about 3 or 4 days after Diwali, had a 40+ lady delivery with IVF, assisted by them. HRT, very important, yes or no? Hypoestrogenemia may require HRT. There is some evidence that restoring normal estrogen levels will reduce the later development of cardiovascular diseases, osteoporosis, and possibly dementia. Cardiovascular disease and osteoporosis are biggest advantages. Many forms available, tablets for use, creams, vaginal rings, transdermal patches, subcutaneous implants, and this is the dosage schedule. Dr. Vandana Ben in her comment said that they are notoriously developing urinary infection. Short-term HRT in them helps, and she knows it. Estrogen mitigates all, but not some, but not all, but it is an effective treatment option. Short-term is good. What is not helping? Surely not helping. Diet and not proved. Please, I am a teacher and a scientist. Diet and exercise is no scientific consensus or proof that they can restart menstruation in premature menopause. And last, other methods, stress reduction and orgasm. It is said that more orgasmic sexual intercourse you have, you will have less chances of developing premature menopause. It is bunkum. So friends, to sum up, premature menopause is distress. Not only for the lady concerned, but even for us. We feel for them. It is surely distressing. But if you have the knowledge of what is happening, experience and skills, and keep on reading, and not let pharma company teach you pharmacology, but teachers teach you pharmacology, which includes books and even AI and everything, then both you and the lady can dance. Thank you, ladies and gentlemen. Thank you so much. We can't hear you, Rashmi. We can see you. You are very beautiful to look at, but we can't hear you.
So thanks, sir, for that awesome presentation. And now over to Dr. Kanchan Sharma for our expert comments on Dr. Pankaj Desai's sir talk. Since Dr. Shubha Sethia has not been able to join, I am requesting Dr. Kanchan Sharma to give her comments on Dr. Pankaj Desai sir's talk.
Actually, I was muted, so I was not able to speak. First of all, my regards to ICOG President Chair Dr. Parag Binwale sir, and an excellent talk by Dr. Pankaj Desai sir as usual. It's always bringing out something new and something special for all of us. And my congratulations and good wishes to Dr. Archana Dwivedi, and she is a chairperson of Midlife Committee and always does wonder, and she has done many workshops and conferences with me, and my good wishes always. I am seeing Dr. Manju Verma madam, she is also very senior. Dr. Sarita madam is there. Thanks and greetings on my behalf. Dr. Maninda Oja madam is there. Madam, your talk was wonderful. So regarding the talk by Dr. Pankaj Desai, इनका तो टॉक मतलब बिल्कुल एक इन्होंने गागर में सागर भर दिया like that, and he narrated each and every point wonderfully, what we need and what a menopausal or midlife person can do, and what is the AI and what further we can do. And excellent talk sir, that is enough. But आपकी को summarize करना मतलब सूरज के आगे दिया दिखाना है. Everything was very perfect and wonderful. My regards.
Thank you, all the esteemed chairpersons and speaker for the first session. Now, since of lack of time,
to go because my dinner has been served. Will I be required for anything else?
Sir, we'll have the question answer session at the end if you can join us again after 1 hour.
But any question answer session, anything is there?
The last in
then
the end, it would be there, sir. So if you can spare
At
time, I'll call
approximately
and
Try
remind
to.
you.
Sure. Thank you very much. Sorry for
at
bothering you.
approximately
We'll call,
7
sir.
o'clock, sir.
Pardon?
At approximately 7 o'clock, we'll have the question answer session.
Yeah, I will try to. I will try
You
to.
can have your dinner and back.
Hopefully.
Okay.
Thank you.
Before we end, sir, thank you so much, Dr. Pankaj Desai, sir, for giving such a insights on that subject. Thank you so much, sir.
Thank you.
So moving on, we are going on to our second session, that is on lifestyle. And I invite the chairpersons for this session, Dr. Aditi Rathod, who is from Jaora and currently the secretary of the Ratlam Obstetric and Gynec Society. The second chairperson I invite is Dr. Neeraj Jadhav, who is a vice president elect of Foxy 2027 and was a past chairperson of the sexual committee, sexual committee. And the next chairperson is Dr. Kanchan Sharma, who we have already heard once. Now, she's also a senior consultant at Akash IVF Kanpur, and she has several academic laurels to and publications to her laurel. And welcome, Kanchanji. And we'll have I will now introduce the speaker and have the talk, and then we'll have invite the chairpersons to give their comments after each session. So the first talk is on sleep hygiene, a very important topic by none other than our current chairperson of the Midlife Committee of Foxy, Dr. Archana Dwivedi. And this talk is relevant because, as previously mentioned by Dr. Pankaj sir and others, sleep disturbances may be the first complaint experienced by menopausal women. Over to Archana. Archana, unmute कर लो.
Okay, thank you, Reshmi, for the kind words. I think I'm the last moment roped in person because Dr. Nimit
You are
is
the
not
first
a...
person to have been coming.
So I would just share the slides. And before I share, Sadar Charan's first to my teacher, Dr. Manju Verma, madam, who's here with me. And it's always a delight to speak in front of madam. It becomes very, very motivating for me. I hope my slides are visible to everybody.
Yes.
On the show mode, right?
Yes.
So thank you, Reshmi, for the acknowledging that. And I'm very, very thankful to the ICOG team, Dr. Parag sir, and Dr. Sarita Balerao madam, and Foxy President Dr. Sunita ma'am, Dr. Suvarna ma'am, for giving us the open hand to talk about and do as needed. And now my topic, which I'll be talking about, is menopause and insomnia. What's burning? Oh, it's me. That's the most of the time the female is complaining. And actually, these things pile up and become a volcano till the patient comes to us. So insomnia and menopause are very closely linked.
I think you
There
can make it full screen. Full screen. It is not full screen.
तो slide show पे करके हाँ.
I'll just share again, no problem.
I think now
it should come. Okay. Can you see this now?
We can now see you on.
The slides can be seen.
Yeah, it is now on slideshow.
It's not on slideshow?
It is on slideshow.
Okay, fine. Now, so I'll be just talking about it again. I'll start. So insomnia and menopause are very closely linked because of the hormonal changes. There are the changes which is our experience in the sleep pattern. So today we'll be discussing about the comprehensive management during menopause. Why? Because women are more likely to suffer from sleep disorders in comparison to men during their midlife and advancing age. And if we talk about the prevalence, almost you can say 16 to 47% patients during perimenopause do experience that. And at postmenopause, it becomes 35 to 60%. I would not spare the andropause entirety also because males equally suffer from this, but we don't talk about it much. There was a shocking index where the RTI is reported by 11% when we talk about the roadside accidents. But nobody talks about the accident which reaches up to 47% when there's an insomnia which is observed in the patients and later on when they are driving the vehicles. So the sleep-wake disorders can be manifested as insomnia, hypersomnolence disorders, narcolepsy, breathing-related sleep disorders. There can be circadian rhythm disturbances, sleep-wake disorders, non-REM sleep arousal disorders, nightmare disorders, behavioral disorders, and the most common is restless syndrome, or there may sometimes be a substance or the drug abuse as well, which is leading to such type of pattern. So we need to classify the insomnia. There are two classes of classifications. One is American Academy of Sleep Medicine, which takes into account there's a difficulty in initiating the sleep. They are not able to maintain the sleep, or the restoration of sleep is becoming difficult, accompanied by daytime impairments such as fatigue or difficulty with memory or concentration, which are related to their sleep difficulty. Other class is International Classification of Sleep Disorders, where it further specifies 10 subtypes. If the patient is meeting with adjustment insomnia, psychophysiological insomnia, paradoxical insomnia, idiopathic, inadequate sleep hygiene, or due to some mental disorder, drug or substance abuse, or there's a medical condition, or where you cannot specify the insomnia, and sometimes there is a physiological insomnia. So what causes this sleep disruption or insomnia? We have to understand there are primary disorders, there are host factors, there are health related factors, environment is equally responsible, and there are medications which have direct effect on the sleep and indirect effect on the sleep. Age, we all know, there it comes with a package of cognitive impairment, response to stress, sleep related beliefs, sleep habits. There can be pain, depression, nocturia, anxiety, heartburn, cough, or maybe in a inappropriate environment. There's too noisy, the temperature is not good, there is medical or personal care is not available, social interaction is not there, or sometimes partner's habit like snoring is most common to talk about. There can be substance abuse like alcohol, tobacco, or caffeine. Now we know that there's a definite overlap when we talk about the symptoms of menopause, because there is brain fog, there is fatigue, there is anxiety, depression, there are so many orthopedic problems, loss of libido, irregular cycles, vaginal dryness, heartbeats are irregular, breast pain is there, there's change in body odor, dizziness. All these things are some or the other getting a contributory factor when we talk about insomnia during menopause. As we said already, there's difficulty to fall asleep. Patient tends to wake up frequently. They wake up too early and they are not able to go back to sleep because they feel tired, groggy, and unrefreshed the very next day. So why does this menopause affect? We all know that the hormones leading up to or during after the menopause, estrogen, progesterone, the GnRH, FSH, LH, we all talk, these all together, reproductive hormones cause the vasomotor symptoms, and circadian rhythm is getting disturbed. There is mood change, there is metabolic disturbance as well going on. We all talk about gut health more nowadays. So low estrogen levels can contribute to weight gain, which in turn contributes to development of snoring or sleep apnea. Tongue is falling back, and the regulation, the neurotransmitters are responsible, which are important for mood regulation. There, this is also getting interfered. So patient is more predisposed to anxiety, depression during the transition phase. So these shifts leads to hot flashes, night sweats, and they cause such type of disturbances. Again, coming more precise, what estrogen does and what progesterone does. We all know progesterone stimulates the benzodiazepine receptors, gamma aminobutyric acid receptors, and thus it is a sleep inducer and works as anxiolytic as well. Whereas estrogen is involved in norepinephrine, serotonin, and acetylcholine metabolism, which is going to have a thermoregulatory effect at night, and indirectly it is going to improve the sleep pattern of the patient. This is what melatonin does. Melatonin has got its own physiological antioxidant anti-inflammatory actions. That is, the circadian rhythm is getting maintained, regulation of glucose and lipid homeostasis, regulation of human reproduction, synergizes the oxytocin to promote the nocturnal uterine contractions, provides adequate placental perfusion when the lady is pregnant in their midlife. Whereas later on, there's antioxidant action where inhibition of pro-oxidant enzymes is there. There's decrease in muscle oxidative stress, pro-inflammatory cytokine suppressed, removes the free radicals, and decreases the expression of glial fibrillary acidic protein. Here I would like to mention especially orexin, which is a neuropeptide, plays an important role in promoting wakefulness and impairment of the thermoregulation. So plasma level of orexin is found to increase after the menopause. Hence, by inhibiting the circadian rhythm pattern is getting disturbed, and patient is more predisposed to sadness, irritability, anxious panic attacks, mood swings, low self-esteem, reduced motivation. So this type of perimenopausal or menopausal transition especially when they're suffering from hot flushes, cause lots of disruption of the sleep. And this is also known as domino effect, because nocturnal awakenings are going to trigger the daytime mood symptoms as well. And this is a vicious cycle, which is, if not reverted within 2 weeks, are going to progress into depression, later on dementia, Alzheimer's, many things follow. So there are consequences like fatigue and lethargy next day, mood disturbances. There is decreased cognitive function and increased risk of chronic disease if there's a long-term insomnia, especially the cardiovascular risk, diabetes, obesity. And now this is when knowing this is a very important predisposing factor to many underlying sequelae of comorbid condition. We need to manage insomnia very well when there is a window of opportunity by adopting a comprehensive, individualized, tailored approach to the patients who are suffering from insomnia, and they should be targeted to receive effective management and improving the quality of life. So you have to do evaluation, assess the menopausal symptoms, sleep pattern and overall health, individualize their treatment plan, and always call them for a regular follow-up. And one thing which is very important, collaborate people. You only alone cannot own the menopause and the disturbances, the transition. So we have to go hand in hand with the sleep hygiene expert, the gynecologist, psychologist, and sometimes hypnotherapy is something which is coming up in a very big way. So talking about the pharmacological management, we all know that in 1963, the first benzodiazepine, namely chlordiazepoxide, was started in 1970. Flurazepam came into action, where the sleep quality, wake up sleep time, total sleep time, sleep efficiency, it was acting on every phase of the life and was giving good treatment. Later on in 1992, zolpidem was first non-benzodiazepine receptor agonist, where the changes in body composition, increased comorbidities, polypharmacy, pharmacokinetics in older adults required more careful prescribing of all these medications. So this had a relatively fewer side effects, binding selective types and producing sleep effect in menopause. As the time evolved, now we have suvorexant, trazodone, doxepine, and melatonin is there to stay. A little word on melatonin, because this is very good. It can be given. Typical dosing starts from 0.5 to 5 milligram, appears safe up to 10 milligram. Headache, somnolence can be there. Fatigue, hypersensitivity has to be taken into account. But there are multiple nutritional supplements. They are marketed for sleep, mostly commonly used at valerian root, chamomile, and kava, which is also helpful. We have experienced in the COVID times. MHT, I will not go in detail for the short of time, but we know that if it is intervened at a proper time in a proper window of opportunity, say 10 years before within the menopause sets in, it is going to give better results. Coming a little word on the now non-pharmacological interventions, where we have to strictly follow the sleep regime, hygiene education. There has to be a stimulus control and sleep restriction. Like daytime sleep should always be restricted, and use of alcohol, caffeine, everything has to be restricted before you go to sleep. You have to maintain a sleep and wake up cycle. You have to instruct your body that this is a time to go to sleep. And please use the bed only for intimacy and falling asleep. Don't do anything else, because the mobile gadgets, everything emits blue light, which is going to hamper your proper sleep. This is very important thing which I would like to highlight, the talk therapy, which was first introduced in 19th century by Sigmund Freud, which improves the person's behavior and thoughts which are not within their conscious control, and focuses on their childhood and past event also, which is causing some type of anxiety, panic attacks. So this psychoanalytic and psychodynamic therapy, developed so nicely, has to be taken into account by psychotherapists, trained therapists, and they help the patient to develop healthier coping mechanism towards their mental issues and the midlife mental health. This has got 4 components: CBT, DBT, psychodynamic therapy, and humanistic therapy, interpersonal therapy, where these 4 components restructure the patient in order to, they're exposed to this and there are role playing where they find their solutions themselves by mindful relaxation techniques as well. So they are able to cope up stress in a better way. See, you can see this picture very nicely depicting when there is a jamming of thought, when you talk to somebody, take help, suddenly the things become very sorted out, and it is very powerful. The talking is there to stay. The CBT therapy is going to stay. So coming on the last few slides, where I'll be giving you the 5 pillars. Pillar 1 consists of sleeping schedule. Go to bed early, go to bed and wake up at the same time every day, even on the weekends, because it helps to regulate your body's natural sleep-wake cycle. Determine your ideal bedtime, counting back 7 to 9 hours from the desired wake-up time. Stick to it as much as possible. If you need to shift your schedule, do it very gradually. Avoid lines because they disrupt your rhythm. Optimize your sleep environment by making it silent, dark, cool. Have comfortable mattresses and pillow. Clean and tidy, clutter-free bedroom. Bedroom for sleep only. No TV, no mobile because this blue light is going to harm your sleep pattern. Develop a relaxing bedtime routine. The goal is to signal your body and mind that it is time to wind down for sleep. Choose what works for you. Aim 30 to 60 minutes before the bed. Warm bath, shower, reading a book, gentle stretching, listening to calm music, meditation, deep breathing, journaling, or aromatherapy can also be helpful. Again, be mindful of what you consume before you go to bed. Caffeine, alcohol, heavy meals, nicotines have to kept aside. You have to have a light meal and preferably 3 to 4 hours before you actually maintain your sleep pattern. Pillar 5 is your daytime habits also influence your sleep. So have a regular exercise pattern in the morning hours, have some adequate sunlight exposure, nap wisely. Managing stress and worry is very important. Here I would like to focus, designate a worry time. Don't feel free that the stress is going to live with us. So have your worry time earlier in the day so that you can address your problems in an adequate way. Write it down. Think that what is our priority and delineate your work very nicely. Practice relaxation technique throughout the day, which is very, very important. So coming to the end of the slide, I would like to highlight there are some common sleep myths and facts. Myth is that you can catch up on your sleep on the weekends. It is a myth, a complete myth. We as a gynecologist stay whole night is gone, no sleep is there, next day we think we'll sleep on the weekend. No, find out time for the power nap, and the very next day you need to schedule your sleep in such a way that you are re-energized for the whole week. Don't wait for Saturday, Sunday. And there is some recovery which is possible, but chronic sleep debt cannot be fully repaid. So consistent is the sleep key. Alcohol helps you sleep better? No, it fragments your sleep and reduces your quality of sleep. Watching TV in bed helps you to relax and fall asleep. The blue light, as I'm talking about, stimulating content can disrupt your sleep again. Older adults need less sleep? No. Every adequate adult, there's adequate sleep time is 7 to 9. Now, I would like to highlight here, don't bother yourself that you have to sleep 7 hours, 7 hours. That if you keep that in mind, your sleep is again going to be disrupted and fragmented. Another thing is that remove the bedroom clock because that tick always reminds you that you're not able to sleep. First thing what we do whenever we get up at mid of the night, we see what is the time. So that is not a right way to practice. So here, before I end my session, I would like to tell a take-home message that eat well, exercise well, do not forget to sleep well because every day when you get up, you breathe and this breath is actually, you should be proud that you are here, you're finding your way into this and have a blessed day ahead is very, very important with this beautiful pack which you can put on your eyes if you want to sleep. So thank you so much. I tried to finish most of the things in this due time. I hope I was able to justify that because it is very, very important to have a happy menopause and happy midlife. Thank you so much for patient hearing.
Wonderful, Archana. You are a perfectionist, as always, I say. And you very well covered all the points. The sleep is very important for all of us, as is the eating and proper the lifestyle. So sleep is very important, and the proper 7 to 9 hours sleep, as you explained very well, is very important for all of us. And there are different techniques which you have to just to get the proper sleeps. Before sleeping, as the blue light, especially that interrupts. Now, there are a lot many ads even the YouTube that if you see mobile while sleeping, and that especially stimulates your pineal gland and has disturbance in the theta waves of the brain, which are necessary for the sound sleep. So you have already very well explained that keep these gadgets away and try to remain away from the blue light. Thank you very much. It's wonderful.
Thank you, Dee. Thank you so much.
To you. Yeah.
Rishmi, you can unmute and we just get to another session.
Thank you, Dr. Kanchan Sharma, for your comments. And I think a warm glass of almond milk would also help on a lighter note. Now over to, it will be my proud privilege to introduce Professor Manju Verma, who is also Dr. Archana's teacher, to speak after Archana. Professor Dr. Manju Verma is a well-known teacher, past president of UP chapter OBGYN, and she has got several accolades to her in her kitty, but I will not go into the details and not stand in between the academics and the delegates. Over to Professor Manju Verma, madam.
Unmute किया
मैडम हम अनम्यूटेड हैं, बोलिए.
So I would like to thank the ICOG officials and Dr. Dr. Archana, Dr. Rashmi, and all the delegates who are already present over there. My heartfelt thanks to you people. And then I would not waste time in just speaking such lines. And Archana, I really remember you always, whenever I think about you, I remember you. Then the topic allotted to me today is the NCD. And as everybody knows, that the NCD is a rapid health transition with a rising burden of NCD in India, right? So causing a significant morbidity and mortality both in urban and rural population. This is why it is very important to know something about the disease,
Make it on
NCDs.
slide presentation.
What is?
And
It
this
on
is
slide
not a full
presentation
screen.
mode.
Full screen. Full screen is
Full
not there.
screen.
Full screen, okay. Full screen. Well, I have a helper with me who's been helping
This
me
is the
out.
right icon, madam. Right icon. Just press there.
I only can operate on my iPad. I can't, and it is a little difficult. So I have called somebody who's doing it for me. So just to continue, so NCDs are always known as chronic diseases and tend to be of long duration and are a result of a combination of genetic, physiological, environmental, and behavioral factors. The NCDs disproportionately affect the people in the low and middle income countries, where more than 3/4 of the global NCD deaths occur, counting to about 32 million. Now, just in short, it is caused by the sedentary style, the stress which is the person takes, poor dietary choices, syndrome acts. That is what it is also called. And most of the time it is associated with adiposity, and this is basically at the truncal level. And this is just the findings. If the two are present, then we always call that it is an NCD. Now, triglyceride may be high, the cholesterol may be high, the blood pressure or the glucose. These things can be biochemical tests. Two of them have to be high for to be labeling a person. Now, coming on to the global burden. Now, it kills 41 million people each year, and which is equivalent to 71% of all deaths globally. And it is associated with older age group, but evidence shows that 15 million of all deaths attributed to NCDs occur between the age of 30. Mine, it is 30 to 69. So we have to be very, very careful, starting from the very beginning of the adult age to start doing something for it. About 85% are estimated to occur in low and middle income countries. The four group of diseases account for about 80% of premature NCD deaths. The basic ones, they are the tobacco use, physical activity, the harmful use of alcohol, and unhealthy diet. All increase the risk of dying from an NCD. So detection, screening. I think screening should be first, and then detection, and then treatment of NCDs as well as palliative care are key component of the management of NCD. Now, this is again a national level statistics in which the cardiovascular, the mortality is 27%, contributed 13% by cardiovascular, and other NCDs as a cancer 26%, and communicable maternal perinatal nutrition condition 11%, and chronic disease respiratory by 11%, and injury due to diabetes is 3%. Now, the risk factors, I think, can be divided into modifiable and not modifiable. And I would like to skip because this has been given. The particular things that one should remember about these NCDs are that they have a long latent period, So, one can have an example of cervical cancer. The infection occurs much earlier, and the disease takes approximately 20 years to come. And all these come, chronic diseases by many years it has been preceded, and they include hypertension, diabetes, and stroke. And another thing is there is an indefinite onset. While we have a communicable disease, the person gets an infection, and within 3 to 5 days, the period the person has symptoms. But as far as the NCDs are concerned, the onset is not definable. Now, coming on to the proper topic of screening is that the regular health screening are essential part of our preventive care. And optimal health issues before symptom occurs allow for early treatment and better outcome. There are three main types of health screening: primary, secondary, and tertiary. Each serves a different purpose in maintaining and improving health. Primary screening basically is used to identify risk factors before a disease develops. The goal is to prevent illness by addressing these risk factors early. And example is blood pressure checkups to prevent hypertension, cholesterol for heart disease, blood sugar for diabetes or pre-diabetes. These screenings are often recommended for healthy individuals and with low symptoms, but who may have risk factors for like family history or a lifestyle habit which is there. Secondary screening basically is focused on the early detection of disease in people who show no symptoms. Catching conditions early can lead to more effective treatment. Example of a secondary screening is mammogram for breast cancer, colonoscopy for colorectal cancer, pap smear for cervical cancer. And these tests are usually recommended based on age, gender, and risk factors. Now, these are the stations on which the screening is being done. The patient entry, and goes to the station 1 where the class registration is done. The second station is to measure the GC, pulse, BP, GC, height, weight, and calculate the BMI. Then station 3, there is a measurement of how BP is taking place and calculation the CVD risk. Then station 4 basically is the blood glucose testing. If the individual is not in fasting, the person should be called the next day with a minimum of 8 to 10 hours of fasting. I think it was used to be 12, but I think it has been reduced to 5. The station 5 is clinically to review anthropometry. That means, and of course, blood glucose, blood pressure, CVD score, and provide targeted interventions at the station 4. Then station 6 is the documentation that occurs. So this is basically how if a person enters, the things are being done. The screening can be, can be the patient comes, it's a general screening, and the other can be a patient comes to the OPD and then it is being selected. So the two types are different. Now coming each one, now with the registration, the patient age, sex, and number, all these things are being recorded, and the anthropometry is done. I have already said, to height, weight, and calculate BMI. Station 3 is blood risk, blood pressure, and cardiovascular risk is done. Then fasting blood glucose is taken. Usually the patient age is 40 years, but nowadays it has been reduced to 30 years. And with below 40 years, the patient who are overweight and obese, that means more than 25 BMI, and first degree related with diabetes mellitus, history of gestational diabetes, and fasting capillary blood glucose testing is to be done with the fasting of 8 to 10 hours. Now this again is a clinical assessment which is being done for all the things, and then this is how the things has to be monitored. This is a form which is being which should be filled before the patient leaves. So coming on to all these things has been done, we come to the metabolic health exercises, the second part of my talk. And this is basically the metabolic workout, also is known as metabolic conditioning or metabolic resistance training. It is a workout designed to more efficiently burn energy using a combination of high intensity and moderate intensity exercises. Metabolic workouts are typically circuit training workouts where on individual or in groups move from one workout station to the next to perform a variety of compound exercises. Now, the times vary. They are typically 20-minute workouts. Many high-intensity interval training workouts are form of metabolic training programs. However, not all HIIT workouts fall into this category. Now, the effects are basically that there is a form of muscle build-up. The strengthening exercises will build up the muscle, and they are the full body workouts. They will make the person efficient with the program basically involve compound movements with combined elements of cardio, weight training, body weight training, and resistance training. Most metabolic workouts are considered circuit training workouts, in which exercises move from one workout session to the next to quickly practice a variety of compound exercises. Now, burn fat post workout metabolic exercises have the effect on this, and they are designed to trigger on an after burn effect. The scientific term for this effect is post exercise oxygen consumption, EPOC. Oxygen burns body fat and metabolic rate is increased. Now, whenever a person is doing exercise, there are very number of advantages that are there. They're 50% of more likely to quit smoking. 40%, these are the studies the studies which have shown 40% are more likely to eat less and eat more of the red meat, 30% more quickly to cut down on caffeine, and 2% are likely to eat, 25%, this is wrongly there, are likely to eat low calorie foods, and 25% more likely to cut down on salt and sugar than the non-exercising exercisers. Now, the other thing is these exercisers tend to have more positive feeling about their health, more positive feeling about their careers, and more aware of stress and adaptation stresses. So there are a number of advantages when a person is doing exercises. These are the benefits, over the adiposity, over the abdomen, and then in the brain, heart, lungs, and in blood. All these changes are there. So though it becomes very, very beneficial to the whole, to the person in and all the systems almost. The strength exercises basically are those to be done at home. They will improve your health and mobility. And the strength exercises are basically divided into sitting exercises, flexible exercises, and balance exercises. The aerobics are basically being contributed by walking, running, or cycling, swimming, cross-country skiing, and circuit-type resistance training. Low resistance and high volume. The frequency has to be 3 to 7 sessions spread throughout the week, but both modalities should be represented, and moderate to strong on broad scale. The duration has to be 3 to 5 minutes warm up, followed by a 50 to 60 minute at training intensity. So the currently aerobic and strength training exercises are recommended together because these kind of activities to some extent induce distinct adaptations and health benefits. The idea of training both currently will be now, whenever a person is being subjected to exercises, there are certain precautions that should be taken. If a person is having COPD, if a person is having cancer and the blood is the leukocyte is less than 5,000 per liter, or it is basically the hemoglobin is less than 6 grams, or platelets below than 20,000. If a patient has a platelet of diabetes, blood sugar is more than 30 millimoles per ml, then it should be corrected first. Patient with severe diabetic peripheral and autonomic neuropathy for foot ulcers should be assessed before undertaking exercises. Cases exercise with diabetes with acute illness or infection. Hypertension also has to be corrected first, and osteoporosis. If it is there, then the person has to be taking care about the fall and risk for fractures. The adverse effects also can be there, and therefore they should always be assessed first before a person goes in for exercises. So coming on to the summary, metabolic syndrome is a collection of conditions that often occur together with which increase your risk of diabetes, stroke, and heart disease. The main component of metabolic syndrome include obesity, high blood pressure, high triglycerides, low levels of HDL, cholesterol, and insulin resistance. Healthy eating and increasing physical activity are the key to avoiding or overcoming the problem related to the metabolic syndrome. Thank you. Thank you very much.
Thank you, ma'am. Thank you for this enlightening session. And I think NCD Committee Chairperson Dr. Kanchan Sharma, madam, is here. Who else would summarize it better, ma'am? Over to Kanchan.
really मतलब अगर really अर्चना मैं NCD चेयरपर्सन हूँ लेकिन मैडम तो टीचर हैं. शी इज़ अ टीचर ऑफ द टीचर्स. She has very nicely explained all the thing. Of course, NCD is near my heart, but this is not a small topic. This is a very big topic and needs days and days to be discussed. And I appreciate her in a small moment of time. She covered everything very nicely. Of course, the incidence of NCDs are now increasing day by day, and we have lot many other things which are coming except the cardiac disease, diabetes, and hypertension, metabolic diseases. She has very well taken about the different type of the exercises which is to be done, and stress-free life. Everything, madam, you have covered, and lot many congratulations to you and my
God
regards.
bless. Well, I think I finished in time was probably because
Yes,
I was thinking
Yes.
15 minutes is too less for
Too less
the subject.
for
But
this
then I tried my level best
broad
to do it.
topic. Yeah, that's a total branch, different branch now. Thank you very much, madam.
I talked to madam yesterday. हाँ अर्चना तेरी slides ही बना रही हूँ. Thank you so much, ma'am, for covering it so nicely. Thank you so much.
She's
Blessings
so
to you all.
detailed and
God
always
bless you, and I'm
blessing.
really proud of a few of this, students of mine. I'm really proud of, and one of them are you.
Thank you, ma'am. Thank you.
Thank you, madam.
So we can stop sharing, and Reshmi, you can take it from here further. Please unmute Reshmi. We have a CV of Dr. Anita, ma'am.
So thank you, Professor Manju Verma ma'am and Dr. Kanchan Sharma for the previous session. And now moving forward, I would request Dr. Anita Shah ma'am from Surat to take the next talk. She is currently the president of the Indian Menopause Society, a very senior consultant, an avid reader, and an excellent human being. And she also too has many accolades and achievements to her in a kitty, but not wasting time. I invite Dr. Anita Shah ma'am for her presentation.
Thank you, dear Rashmi, for your kind words, and thanks a lot to dear Archana for giving me this opportunity to come over this platform. Thanks a lot to dear Parag and Sarita Bhalerao for just doing a wonderful this ICOG course. So let me share my screen. A lot many discussion is going on since afternoon. So the topic given to me is vasomotor changes. All of you are knowing very well, vasomotor changes in menopause primarily refer to the symptoms caused by changes in blood vessel dilatation and constriction during the menopausal transition, mainly hot flashes and night sweats. These vasomotor symptoms arise due to the fluctuating and declining estrogen levels that affect the hypothalamic thermoregulatory center, narrowing the body's thermoneutral zone, which regulates temperature. This leads to episodes of sudden heat sensation, flushing, sweating, chills, and sometimes heart palpitations also. VMS are very common, affecting up to 75 to 80% of women during menopause or perimenopause, typically starting when menstrual cycles become irregular and lasting on average from 6 months to several years, sometimes up to 10 years or longer also. The intensity and frequency of symptoms vary greatly among individuals. These symptoms can disrupt sleep and reduce quality of life, and they may be linked with increased cardiovascular risk and other health changes in menopause. The underlying physiology involves estrogen withdrawal, altering the activity of hypothalamic neurons called candide neurons, which regulate body temperature. These neurons become overactive, causing inappropriate dilatation or constriction of blood vessels and temperature dysregulation. Hot flashes begin with a sudden warmth spreading in upper body, face, and chest, accompanied by sweating and sometimes followed by chills. So the hot flashes is a burning issue. Various terminology is applied: hot flash, night sweat, vasomotor instability. Symptoms experienced during transition mainly to and through menopause also. You all are knowing these minutes of menopause, the 7 dwarfs of menopause: itchy, beachy, sweaty, sleepy, bloated, forgetful, and 5 psycho. Most common psychosomatic problems are vasomotor disorders and hot flashes. Others we have discussed a lot: insomnia, urogenital symptoms, sexual decreased libido, obesity, aches and pains, and depression and emotional psychosis. So let us go ahead with hot flashes. On the lighter side, we can say that I'm still hot. It just comes in flashes now. Hot flashes are the blushes of menopause. And hot flashes can have negative impact on quality of life. During post-menopause, hot flashes can remain and they can become a real burden if they are not treated correctly. Lighter side, this type of cartoon might have observed many times. So if consider the physiology, there is a sudden reddening of the skin over the upper body, profuse sweating. Vital parameters are vasodilatation, tachycardia, normal blood pressure, raised skin temperature, and slight decrease in core temperature. What is the mechanism? Low and fluctuating perimenopausal estrogen levels are responsible for that. Sudden downward setting of the central thermostat. Neuroendocrine disturbances involving opiates, norepinephrine, GnRH, histamine, and inappropriate activation of heat loss mechanisms. In addition to regulating the levels of estrogen in the body, estrogen receptors in the hypothalamus also appear to play a major role in temperature control and in the release of noradrenaline. So, looking to the pathophysiology, there is a estrogen withdrawal leads to overactivation of hypothalamic GnRH pulse generator and interactions among catecholamines, prostaglandins, endorphins, neuropeptides, resulting in peripheral vasodilatation. If we look at the epidemiology, most common climatic symptom observed in 70 to 80% of menopausal women, 75% Caucasian women experience hot flashes beginning 2 years prior to cessation of menses, 85% have hot flashes for more than 1 year, and 25 to 50% for 5 years, may continue indefinitely in some women also. If look at the global incidence, there is a wide variations, less than 10% in Japanese women to 85% of women in the Netherlands. There are physiological differences in attitude, culture, societies, and individual perception is also responsible for the variation. The Indian scenario, if we look at that, various studies have been carried out, and it is from 25% to 42%. If we look at the clinical presentation, sudden transient sensation ranging from warmth to intense heat that spreads to chest, face, head and neck, accompanied with the other symptoms as for example, flushing and perspiration followed by chill, rise in skin temperature more than 1 to 7 degree Fahrenheit and may last for 3 to 4 minutes. Average duration is about 4 minutes but can last up to 30 minutes also, and frequency varies from a few episodes a week to several per hour. Onset in the perimenopause related to the onset of HPO axis dysfunction. Maximum incidence 3 months to 3 years after the last menses. And if untreated, symptoms persist for 5 years in 57% of the patient. This is the result of various studies carried out. Are not hot flushes a health hazard? Definitely, they are health hazard. Insomnia and poor quality of life, it can lead. Unsteadiness and rotatory vertigo can be there. Improved bone density through MHT use, it is also found that it gives the best result. What are the risk factors? Premature menopause, smoking and alcohol abuse, lack of exercise, obesity, history of premenstrual syndrome, sometimes in surgical menopause also, and after tube ligation also in some cases it is to be found. We have to, whenever a patient is having or complaining of hot flushes, we have to put the differential diagnosis, because during this age of life, other certain diseases are also common. Maybe psychosomatic issues, maybe stress, thyroid abnormality may be responsible, leukemia or malignant tumors, and certain drugs like tamoxifen, clomiphene citrate, GnRH analogs, nifedipine, ethanol, MSG, and niacin, they are also found to having this type of issues. If we look at the how to evaluate serum FSH level in situations where clinical picture is not clear, hot flush diaries should be maintained, and various research tools can be applied. If we look at the studies on hot flushes, it was found that exit estimates hampered by inconsistent definitions, methods, and cultural aspects. The placebo effect is dominant with a larger perimenopausal population, and small non-randomized trials are abound. How to manage? As usual, first we have to have the proper history should be taken, diagnosis should be made, consultation and counseling is of utmost importance. Usually, whenever any problems of menopausal health is there, we always advise for lifestyle modification. Hormone replacement therapy is the best treatment for vasomotor symptoms. Tibolone can also be given. Prevention and treatment of osteoporosis, selective estrogen receptor modulators, isoflavones, and alternatives are there. If we consider the management, hormonal and non-hormonal, we can use estrogen, progesterone, tibolone, and bioidentical hormones can be there. And in case of non-hormonal therapy, CNS agent like SSRI, gabapentin, calm therapies, acupuncture, phytoestrogens, phytoprogesterone, lifestyle changes, they are there. So if we consider lifestyle modification, we have to explain the patient that she has to avoid the triggering factors, should not take more caffeine containing liquids like tea, coffee. Hot beverages should be avoided. Alcohol and smoking as well as spicy food should be avoided, and stress management is always necessary. Whenever patient is having the effect of these vasomotor symptoms and hot flushes, she should be staying in cold environment, drinking cold drinks, bathing in cold water, using fans and cotton sheets, wearing appropriate breathable cotton clothing. Usually we advise that dressing in layers is definitely helpful. Whenever patient gets this type of attack, she should lie down on the bed under the AC or under the fan, and most of the time she may get a little relief. Stress reduction. Today, everyone is having some type of stress. So one has to learn to remain stress-free. Paced breathing, yoga, meditation, acupuncture, acupressure, all this can lead to relief of stress. Exercise. A lot many things have been discussed. Aerobic and weight-bearing exercise are very important. Optimal exercise is at least 150 minutes of moderate intensity per week. And of course, weight loss is going to definitely help. Conventional menopausal hormone therapy, oral MHT reduce the hot flushes by 80 to 90%, and they are the standard against which other therapies should be compared. MHT is the recommended treatment for vasomotor symptoms. This was also found by ACOG Committee of Gynecology 2001. Which form of MHT should be given? Vasomotor symptoms are relieved even when estradiol levels are as little as 15 picogram per ml. All forms of estrogen replacement therapy achieves this level. So, no risk of estrogen withdrawal leading to a rebound in hot flushes. You all know various forms of estrogen can be given oral, transdermal in the form of patch or gel, subcutaneous implants, vaginal gel, intranasal spray can be given. When estrogens are contraindicated, you can go and you can select tibolone, phytoestrogens, non-hormonal drugs, and complementary medicine. If you look at the tibolone, the occurrence of hot flushes and night sweats was significantly lower in the tibolone group compared to placebo after 12 months of the treatment. It was found by Mason et al. Menopause 2002. Women treated with conjugated equine estrogen and MPA or tibolone showed significant improvement of postmenopausal symptoms. Phytoestrogens, 14 randomized double-blinded placebo-controlled studies were being carried out, and it was found that it also gives relief from hot flushes. Not a single study showed a statistically significant benefit for the use of phytoestrogen as compared to the placebo for the relief of hot flushes. In 3 studies, more than 10% of the population had significant side effects. So whenever we use these, we have to be very careful. Don't give it blindly. Non-hormonal drugs, alpha-2 adrenergic agonist like clonidine. You can also use venlafaxine, paroxetine, fluoxetine, and 5-hydroxy-tryptophan antagonist can be also used. Gabapentin can be given. If we look at the complementary medicine, paced respiration, biofeedback, yoga, Ayurveda, acupuncture, acupressure, Tai Chi, naturopathy, aromatherapy, all can give some help. So, in short, I would like to say that hot flushes, it is an opportunity. 58% of menopausal women seek healthcare due to the hot flushes, an excellent opportunity to initiate preventive health services in the aging population. So, in short, I would like to give take-home message. Hot flushes is one of the indications for short-term MHT. It may not be a major health hazard, but does compromise the quality of life, and which we always care for our patients. If symptoms necessitate longer therapy, alternative therapy can be also used. Hot flushes is an excellent opportunity to initiate preventive health services in the aging population. So, whenever patient is having this type of problem, you always have to counsel the patient properly, and then you can give the best benefit to your patients, because we always want that our patients, each and every midlife woman should remain healthy and happy till the later age of her life. Thank you very much.
Thank you, Anita ma'am, for that excellent talk and with very clinically relevant notes on it. Now I would request Dr. Aditi Rathod to give her expert comment on ma'am's talk.
Thank you, Dr. Reshmi, for inviting me. I would like to thank Team ICOG and Midlife Committee Foxy for having me here as a chairperson for this session. I must congratulate Dr. Anita Shah, ma'am, for such a lucid, excellent, and comprehensive talk. You covered it all well, ma'am. And what I gained from this talk was the most that, as you said, rightly said, that is an excellent opportunity for preventive health. But also, I gathered that I did not know that vasomotor symptoms can also be prevented if we teach the young women coming to our clinic while she's seeking reproductive health, as you said, that lack of exercise, obesity, and smoking leads to vasomotor symptoms. So we can easily educate the women coming here, and because it is both preventive as well as it forecasts also the future health of the woman. Thank you, ma'am. Thank you so much.
Thank you, Aditi, for your comments. And now, carrying the evening forward, I would now request the next speaker, Dr. Padmini Prasad, ma'am, for her talk. Can we have Dr. Padmini's CV? I was first introduced to Dr. Padmini during COVID times when she took a session during the sexual committee workshop. And she's a consultant obstetrician, gynecologist, sexologist, and a marriage counselor. And she's the first qualified woman sexologist from Karnataka. An excellent speaker. I'm really impressed by her talk. And an excellent academician, and looking forward to her talk. Over to Dr. Padmini, ma'am.
Can I share my?
Yes, ma'am. We are waiting.
I'll just share. Want to be lost. Namaste. A very good evening to you all. I am really I should feel so lucky for gaining so much of knowledge and education by such nice talks by these stalwarts. And thank you very much for making me a part of this whole educative sessions. And come to today's topic, sex is not about three letters. It is about three words: health, happiness, and harmony. To understand what I am talking or what I am taking you through my slides, so I'll give you few examples before I go through my slides. Recently, one of my patient, she came so depressed and she was avoiding all her social activities. When I asked her, why are you were so bubbly and energetic and attending all the activities, and why are you avoiding these days? No, madam, because I am really have got some problem. I always there is some urination whenever I smile or cough or do some pressure exercises. So I am really worried and how to control this. So I am avoiding all the activities. And another lady who was so very active on the dais and all the functions and the dais activities, she was shunning, she was avoiding coming to the stage. I asked her why. No, I am so embarrassed because I have to make so many frequent trips to the washroom because I have got urgency of urination. And another person and a couple came to me and the husband complained the wife is not interested in sexual intercourse after her delivery. And when I asked the wife, why are you not interested and why your husband is not happy? She told me all the time he will be complaining and teasing me that my vagina is loose and he will go to some other lady and we are not enjoying the sex. That was her problem. And another an important article I had to go through a celebrities article who had just written. Really, it was so surprising and so very important for the woman to have quality of life whenever it comes to social activities and other things. So she had written in one of the nightclubs, a cabaret dancer. Suddenly, she was dancing and she poured in that so AC room and such a cold environment. She poured the whole water on herself and becoming completely wet. Later, she went and asked her, why did you do like that? Did you not feel so cold in this environment? She told her, it seems, no, madam. So I couldn't control my urgency of urination. So to avoid embarrassment, I poured water on myself. That was the article really which caught me surprised. And another one Australian sexologist in a conference told me, so her husband told her the previous day, next day, he was supposed to undergo an operation for cancer prostate. He told her, it seems, honey, this is the last time that you are going to appreciate or enjoy ejaculation. So that may be the reason. So all these things to improve quality of life of a woman after pregnancy, childbirth, and to increase sexual pleasure, pelvic floor plays a very important role. Otherwise, all these embarrassing situations which I enumerated may affect or disrupt the social activities, the careers, and also the relationship. So let us understand what's the role of pelvic floor, how we can prevent such embarrassing situations, how we can give a good quality of life to our women. Sex and pelvic floor. Which woman would like to socialize and take active participation in various activities when she needs to make several trips to the restroom, is worried about wet underwear, and smells of urea whenever she laughs, coughs, or sneezes? How many women complain about lack of sexual satisfaction after one delivery? How embarrassing can it be for a woman who cannot hold her feces or flatus at odd times? So this is another story, not lasting long enough in bed. There is nothing worse than that embarrassing moment or ejaculating sooner than you and your partner wish, such as before intercourse begins or shortly afterwards. That is the premature ejaculation. The look of disappointment and occasionally anger can mess with you psychologically. Oh, that PC. What is this PC? It's not Priyanka Chopra, and you will understand what is this PC. Pubococcygeus muscle. Pubococcygeus and pelvic floor, one has to understand the integrity of pelvic floor. The pubococcygeus muscle or PC muscle is a hammock-like muscle found in both sexes. It stretches from the pubic bone to the coccyx, forms the floor of the pelvic cavity, and supports the pelvic organs. It is part of the levator group of muscles. The PC muscle runs from pubic bone to tailbone in a figure of 8 around genitals and anus. You can see how nicely it gives support to the bladder, uterus, and the rectum. The origin, it is from the back of the pubis and from anterior part of the obturator fascia. It is directed backwards, almost horizontally, along the side of anal canal towards the coccyx and sacrum and gets attached to them. Between the termination of the vertebral column and the anus, the two PC muscles come together and form a thick fibromuscular layer lying on the anococcygeal raphe formed by ileococcygeus. The nerve supply is S234 and also parasympathetic. So you can see in this figure how this, you all are very familiar with these figures and the anatomy of the pelvic floor and the muscles. So I don't go into the details of it. This is the lateral view. You can see how the muscle is supporting all these three major organs in the pelvis. And this is in the male, how it supports the bladder, urethra, and also rectum and anus. What are the functions of this pubococcygeus muscle? The PC muscle supports uterus, bladder, bowel. It controls urine flow, contracts during orgasm, aids in urinary control, aids in bowel movement, aids in childbirth. A strong PC muscle has been linked to a reduction in urinary incontinence and proper positioning of the baby's head during childbirth. So a strong PC muscle, a strengthening of this pelvic floor muscle is very important to treat or prevent vaginal prolapse or uterine prolapse, treat fecal incontinence, prevent or treat urinary incontinence in both men and women, treat prostate pain and swelling due to benign prostatic hyperplasia and prostatitis in men. It increases sexual gratification. The conditions which put stress on pelvic floor muscles are pregnancy, childbirth, overweight, aging, chronic cough, genetic predisposition to weak connective tissue, and abdominal surgery like cesarean section. So what is the main treatment or the preventive things that we can advise our women? So one has to understand Kegel's exercises. Kegel's exercises are series of pelvic muscle exercises designed to strengthen the muscles of the pelvic floor. How to strengthen the pelvic floor muscles? Dr. Arnold Kegel developed exercises in 1948 as a method of controlling incontinence in women after childbirth. It is now recommended mainly for urinary stress incontinence in women, urinary incontinence in men after prostate surgery, people with fecal incontinence, and also sexual dysfunction. The success of these exercises depends on proper technique and sticking to a regular exercise program. Weakening of pubococcygeus muscle can be assessed by digital examination of vaginal pressure or Kegel perineal meter. What are these benefits of these exercises? Number one, urinary incontinence. Cochrane collaboration concludes that pelvic floor muscle training is considered first-line management for women with stress, urge, and mixed urinary incontinence, especially useful in stress incontinence in perimenopausal women. Stress incontinence, that is the leakage of urine that you all know, 10% of middle-aged women above the age of 40 years experience frequent episodes of urinary incontinence. Sexual function and urinary incontinence. Urinary incontinence can have a significant impact on sexuality. It can affect a person's feeling of sexuality and confidence in sexual relationship. Leakage of urine may make a person feel embarrassed, anxious, and less feminine or masculine, and may also avoid the sexual relationship. Data from another study showed that only 48% of women with stress and urge urinary incontinence have regular sexual intercourse. Of these patients, 23% had episodes of incontinence during coitus, while 25% did not achieve orgasm. Sexuality is an important issue which needs to be addressed with sensitivity and compassion. The pelvic prolapse. You all know that how the pelvic prolapse can happen because of the weakening of the pelvic floor muscles and the tissues. When pelvic floor muscles weaken, pelvic organs descend and bulge into the vagina. This can lead to uncomfortable pelvic pressure, mass per vagina, and interfere with sexual relationship. The benefits include the prepare the pelvic floor for physiological stress of later stages of pregnancy and vaginal childbirth, during pregnancy and post-delivery for comfort and prevent urinary complaints, to improve sexual function and improve the orgasm, prevent postmenopausal vaginal atrophy, to prevent fecal incontinence. So it is very, very important you teach this to the pregnant women, the ladies after childbirth, after operations, and in the menopausal years. So the teaching about Kegels to your women is extremely important. In benefits of men, and I was describing it to you, it helps to achieve stronger erections, gain greater control over ejaculation. Research also indicates Kegels help restore erectile functions in men with erectile dysfunction, and sometimes they may have multiple climaxes without ejaculation sometimes. The exercise lifts up the testicles, also strengthens the cremasteric muscle as well as the anal sphincter. So because of these things, in post-prostatectomy, urinary incontinence can be prevented by teaching this. The most important thing you all should know is how to do Kegels. First is identifying the right muscle. Isolate and exercise the correct muscles. Try to stop the flow of urine midstream by tightening the pelvic floor muscles. Repeat this action till you learn the feel of contracting right muscle. This is one method. Another one is insert a finger into the vagina. Try to tighten the muscles around your finger as if holding back urine. Insert a finger into the rectum. In men, it can be tried. Try to tighten the muscles around the finger. Using a vaginal cone, sometimes these vaginal cones are available, which is a weighted device that is inserted into the vagina. Try to contract the pelvic floor muscles to hold the device in place. Electrical stimulation, using low voltage electrical current to stimulate the correct group of muscles using an anal or vaginal probe. This can be done in clinic or at home. This is when you are teaching your women. Biofeedback training, it is a method of positive reinforcement. Electrodes are placed on the abdomen and along the anal area. Sometimes it may be placed in the vagina in women or anus in men to monitor contraction of pelvic floor muscles. A monitor will display a graph showing which muscles are contracting and which are at rest. So the therapist can help them to find the right muscle. So you should also understand what are the things that should not be done. Don't flex the muscles of the abdomen, thighs, or buttocks. Discomfort in the abdomen or back while doing exercises shows that PC exercises is not done correctly. Don't hold your breath. Don't relax, breathe quickly, and tighten muscles another 2 minutes. Relax, breathe freely, and tighten muscles around vagina or rectum. Don't make a habit of starting and stopping your urine stream each time. Doing Kegels with a full bladder or while emptying the bladder can actually weaken the muscles. It can lead to incomplete emptying of bladder and increase urinary tract infection. So performing the exercises, empty the bladder, sit or lie down. It can be done at any time or any place, even during other routine tasks. Contract the pubococcygeus muscle. Hold the contraction for 3 seconds, then relax for 3 seconds. Or tighten the muscle and hold for a count of 10. Relax the muscle for another count of 10. Repeat 10 times. Do 3 times in a day. Once 3-second contractions are perfected, try it for 4 seconds at a time, alternating with 4 seconds rest period. Work up till you reach 10 seconds contractions with 10 seconds relaxation. Some people feel that they can speed up the progress by increasing the repetitions and the frequency of exercises. If I do 10 times, 15 times, I may have the proper effect. So that is wrong. This can weaken, like any exercise, overdoing it, it can weaken the PC muscles. So there are also some exercises, what we call Kegels exercises are available. These are barbells, springs, and rubber bulbs, where it can be kept in the vagina and it can be compressed over that to understand. So these are also available to do the Kegels exercises, but which is not needed. A simple method can be taught. These are the barbells and exercises. So when to expect results? Bladder improvement is seen after 3 to 6 weeks. Some improvement can be seen after a few weeks in some. It has to be done for at least 8 to 12 weeks. Kegels in sexual function, as I told you earlier, improves the orgasmic function. It can be used in vaginismus, lax vagina and old perineal tears, and in men in premature ejaculation, erectile dysfunction to improve orgasm. It is very useful in postmenopausal sexual dysfunction. As with other forms of physical activity, one needs to make Kegels exercises a lifelong practice to reap the results and to have the long-time benefits. Thank you very much for a patient hearing. So I think it is very important to understand Kegels and teach them. And if you teach them during pregnancy, childbirth, menopause, and whenever there is lax vagina prolapse, they can have a control over the PC muscle and they can avoid all these problems. When it is too much, then if they need the surgical intervention, so that has to be decided by the gynecologist. Thank you very much for a patient hearing. And
Thank you, thank you, Padmini ma'am, for that awesome presentation, especially how to identify the PC muscle. That is, I think that was, the cherry on the cake of your presentation. And over to Dr. Neeraj Jadhav for his comment, expert comments on his on madam's talk.
Thank you, Padmini Prasad Madam, for a wonderful talk on the pelvic floor muscle. We all know that how important is the pelvic floor muscle to control so many functions related to bowel and bladder, and of course about the sexual function also. And you rightly pointed out that the Kegels exercise is the right way to strengthen the pelvic floor muscle. But it's very important that patients do in right way, because most of the time it's very difficult to do Kegels exercise in a correct way. Unless you do in a proper way, you will not get the benefit of the doing the exercises and strengthen your pelvic floor muscle. And now with the aesthetic gynec, some of the procedures is also available which can help us or patient to strengthen their pelvic floor muscle. So I think that we can cover in the question answer session about the role of aesthetic gynec and the pelvic floor. So thank you very much, Padmini Madam, and thank you to ICOG and Archana for giving the opportunity to chair this session.
Thanks, Dr. Neeraj Jadhav. Nice meeting you. Thank you.
Thank you, Neeraj, for your comments and also highlighting that the exact way of doing Kegels exercise is equally important. And it was, I'm sure the delegates also would have benefited by knowing the technique. So thank you all the chairpersons and speakers for the second session. And now moving on to the third session, which is equally important in this in today's corporate people women going in for financial independence and further education, it being a double-edged sword. We now go on to talk at regarding fertility at midlife. So for this, I would like to invite all the chairpersons, Dr. Niharika Alu, who is a consultant obstetrician and gynecologist at Visakhapatnam and currently the secretary of Visakhapatnam Society and National Faculty for HPV Vaccination. The second chairperson is Dr. Nivedita Datta, who's a consultant OBGYN at Bokaro, and she's also the past president Bokaro OBGYN Society. And the third chairperson being Dr. Poonam Goel. The speakers for this session, the first speaker is my teacher and mentor, Dr. Sushma Bakshi, who is one of the senior most consultants in practicing in Baroda, clinical head of Oasis Fertility Vadodara, and teaching faculty with Telangana University after almost 16 years of tenure at Baroda Medical College. Over to Dr. Sushma Bakshi for a talk on presentation on IVF after 40.
I'm heard.
Yes, ma'am. You are heard and your slides are also seen. They are full screen only, madam.
All right, fine. Is it full screen now?
Yes, it is full screen.
Wonderful. So, first and foremost, congratulations, Dr. Archana and Dr. Reshmi. Thanks, ICOG and Foxy for such a wonderful capsule, which encompasses almost everything in 3 days related to midlife. My topic is IVF after 40. We know that the advanced maternal age is a critical social and clinical issue. And currently, we all are seeing so many of the couples coming at a later age for their fertility issues. The change observed in last 2 decades is that the 15% of rise of pregnancies after 35 and the new normal of elderly pregnant lady is loosely defined at age 40 plus, and that is the change which we have seen. Well, the desire of having babies at whatever age remains as it is, and we have seen so many celebrities also going for having baby and having peaceful smile at the end of successful outcome. The reason is that what has changed in these years leading to pregnancy and fertility desire at higher age, mainly the women in the workforce, the career being given the priority, delay in marriage, increasing divorce, and a delay in reaching to ART services, especially for the rural people, loss of child, etc. And it definitely is a medical challenge over and above the ethical, legal, and social challenge, not only to ART specialists but to the gynecologist also. And what we gain out of this is we have seen this picture that 65 plus year lady has given birth after IVF. But then what we are gaining out of it, the orphan children's, miscarriages, and lot of economical burden. Well, IVF is an answer whenever we go for not conceiving after 35 years of the age. But the question is IVF equally successful at all ages? Age is important. And we are seeing the drastic reduction as per ASRM fact sheet that from 33% in less than 35 years, 0.8% live birth rate in IVF cycle with own eggs. And that is really alarming. It's not only related to female, the male fertility is also affected with the age, and Neeraj was here. There is increase in erectile dysfunction, increased DNA fragmentation in the sperms. Sperm parameters are affected and decline in the capacitation. Huge work has been done by India fertility services market, and you will be shocked to see that it is 2022 to 2033 in 1 decade, there will be 16% rise in the fertility need of the fertility services of various categories and type in India. So why we are focusing so much on the age? Well, we are aware of the fact that there is decline in probability of conception because of implantation failures. There is increase in miscarriage. So even she becomes pregnant, there are chances of losing that baby. Congenital malformation because of meiotic disjunction and aneuploidy is high, and ovarian reserve and oocyte competence both reduce. The question is, do Indian women lose their ovarian reserve earlier than their Western counterpart? Well, it is yes. Epidemiology was talked by Dr. Maninder, and it has been found that there is decrease in AFC and AMH in Asian women earlier than the white women. So how to treat? That is the moot question in women who come after 40 for their fertility issues. They might be coming for the first time for their fertility treatment, having no child, or for secondary infertility, whatever is the issue. So few things which we should remember over here is that the patient may fall into any of the category depending upon their underlying reserve factors and the male factors. So there might be self-stimulation with PGTA. I'll talk about why PGTA. Embryo pooling with self-stimulation with PGTA when AMH is little lesser than average. Embryo donation when the male factor is also associated along with very low AMH. Third party ART definitely has a higher end and role to play in 40 plus age. There is lots of work being done on ovarian rejuvenation with PRP and stem cells. Well, we'll also talk a little about it. And a new window which has opened up of social freezing of egg sperms, embryos, and even ovarian freezing in various situations. The research is going on various aspects of nuclear transfer, artificial womb, but one should not forget, last but not the least, is adoption. So important consideration when a couple comes 40 plus, what should the fertility specialist and gynecologist think about? What is most important is complete evaluation of the couple's health and reproductive organs is a must. You can't delay. Like, I'll not do hysteroscopy just now, and then if IVF doesn't work, I'll do hysteroscopy. Here is a couple who doesn't have time. Proper counseling about the outcome is a must. Say about the success rate, say about the complications, say about the burden of pregnancy, everything, and say about that the financial aspects also. If she needs PGTA or ERA or any other adjuvant procedures, don't shy away of suggesting it. Rule out contraindication and risk of hormonal therapy for stimulation and FET. Choose something which is low risk for her and learn to say no. If the multiple fibroids, poor ovarian reserve, previous failures, well, say no, IVF will not work for you. And this is one of the most important slide I want to tell, that from the entire reproductive age, from less than 30 years to 50 years is being covered. As the age increases, the fertility decline is there and the risk is on increase. And we will quickly talk about that earlier what we can do and later what we can do. So first thing is, less than 30 years, this patient is not likely to marry till 40 years or stop her education for till 40 years. What can she do for her fertility? Best thing is she can do oocyte cryopreservation. So we'll little talk about it. So that is elective fertility preservation, and we all know that being unmarried till late age leads to or reduce ovarian reserve. And for elective fertility preservation, we have various options like oocyte freezing, if her partner is there, embryo freezing, and ovarian activation, which is a research area going on. Various indications of it are there. The social reasons are, I have already said, recurrent endometrioma, premature ovarian insufficiency, what Pankaj said. But what is most important is that less than 30 years, you should go for the freezing of your oocyte or embryo, because it gives the best chances of more than 95% live birth rate. Higher the age, after 35 or 38 years, going for oocyte freezing doesn't help much. So the second thing is, if you have missed this particular aspect and you are reaching to your doctor say around 36 to 40 years, what you need to do is to compensate that. She has average AMH level with AFC also average. So here what you can do is you maximize ovarian response and utilization of the egg, which is most important. So these are the patients to whom you can give her own genetic child. So various ovarian stimulation in midlife fertility protocols are there. Mild stimulation is one where 75 to 150 IU gonadotropins per day is being given, and it is much
strawberry apple सा ले लो ना
it is much
strawberry वड़ी ले लो
appreciated. And natural cycle IVF is told, but it is dismissed now because of cycle cancellation, and outcome is not up to the mark. Conventional stimulation for our Indian population is considered to be very good. Dual stimulation is and embryo pooling is mainly for onco patients. Progesterone prime ovarian stimulation, stop protocol, random start for cancer patients. I'll not tell into details about all the stimulation, but I would like to tell about this, the new progesterone prime ovarian stimulation protocol, and wherein instead of antagonist we give progesterone, either fixed or flexible protocol, and it gives high percentage of top quality embryos and gives good clinical pregnancy rate in women who are aged 40 years or plus. So should be put in mind. So that is, if you are 36 to 40 years, you can compensate. And the third one, which is between 36 to 45 years, well, if you do not have good AMH like 1 AFC or 0.01 AMH, well, there is no good idea to go for ovarian stimulation. Go straight away for oocyte donation, because the live birth rate in donor egg IVF cycles relate to donor's age. So the outcome is better. You can think of surrogacy as a third party ART when there is recurrent implantation failure, recurrent pregnancy loss, and uterine pathology. Ovarian rejuvenation, naturally the lady would like to have her own genetic child, and we can help her by PRP. Stem cell is definitely a research area, and tri-party ART, where is nuclear or spindle transfer, also is a research area. But it is necessary for us to know that we cannot stop the biological clock. And this was unpublished December 2025 Journal of Reproductive Immunology article, and it says that it gives PRP gives good results, but it has very low certainty evidence base. It's not only ovary which is affected. The hurdle race is that with increasing age there is low endometrial receptivity, risk of high dose of hormones is there. Age related medical disorders in both male and female will affect the quality of the gametes. Pregnancy and perinatal problems will be discussed later, and psychological stress and inability to cope up with the child care is also there. So adoption comes up as one more instrument in helping this group of females and the couples, and we must remember that millions of children are waiting for families who can accept them. There is need to build a bridge with that. I'll quickly touch the research areas, and one is ovarian activation. What we do is laparoscopically we remove the piece of young ovary, we make the strips out of it. The fragmentation can be put in the cubes, and then later on you can take out, when the lady's AMH is going down, you can take out those strips and put it under in the mesosalpinx near the fallopian tube, and they, with after stimulation you can go for oocyte retrieval. Even natural conception is possible, and such patients can have babies, and this is being tried in premature ovarian failure patients very well. Just the dramatic schematic representation, the oocyte of old lady has bad nucleus, the young lady has good nucleus, so we just go for the transfer of good nucleus into the patient's cells, oocyte, and all the problems are gone. Artificial womb in those patients who are having uterine problems and cannot go for uterine transplant also should be thought of. So desire of the couple is there to get something out of a uterus and get a baby, but the clinician's dilemma, the litigation, the harm to the patient, the worry of that, and very low success rate really puts the clinician into the soup. So, to conclude, the fertility in midlife, the need for fertility in midlife is on rise. ART usage is on rise, but it has got its own limitations and complications should be thought of. Social freezing of embryos has opened up new fertility dimensions in career-oriented individuals. Medical science cannot eliminate all the risk related to midlife fertility. Judicious use of technology is the need of the day. Indian women ovaries age early by 7 years. Adoption should be offered as an effective alternative in 40 plus couples. And pregnancy in elderly women is high risk, and counseling is a must to couple undergoing ART at older age. We must remember the Hippocrates oath, first do no harm. And new ART law has tried to minimize the risks to those elderly couples and have fixed up the age of female as 50 years and male as 55 years. Beyond that, they cannot have ART services. And with this, I congratulate Dr. Archana Dwivedi and Dr. Reshmi and all, and I thank all the office bearers of ICOG and Foxy for giving me this opportunity to be in this prestigious forum. Thank you very much.
Thank you, ma'am, for that lucid presentation. And it's a really tough topic, technically, and explaining it in such a simple language, that even the delegates attending would understand. And over to Dr.
Reshmi, I would
Niharika.
like to add one thing. Reshmi, I would like to add one thing.
bolo.
Madam is an epitome for us when infertility is there. So when I thought of this topic, nobody else could cross my mind. So thank you, ma'am, for the excellent deliberation, and Niharika is there to take care of the statement.
Thank you.
Thank you, Dr. Rashmi and Dr. Archana, ma'am. Indeed, it was a wonderfully and comprehensively, delivered lecture. And I have to congratulate the ICOG team and the chairpersons for curating this topic in the first place, fertility after 40, because I think it's the need of the hour. And Madam rightly pointed out the reasons and also pointed out not just the female, even the male infertility also you have to consider. When you have women at 40, the partner is invariably going to be aged. So that, and also very beautifully pointed out that Indian women, we see a lot of early aware in aging these days. And I think I had two slides which really brought out everything, the fertility and risk slide and the last two slides. I think that summarized the whole essence of the topic. Beautifully done, ma'am. Thank you so much for pointing out the newer modalities. And I think the next two topics will also take care of the thing that we are actually facing. We have a lot of women these days who are around 40, and we are having to see them now. So we need to learn all of this. Thank you so much.
Yeah, I cannot agree more with this, Dr. Niharika. Thank you very much.
So moving on to the next session, Dr. Narendra Malhotra could not join us in person, but he's somebody who needs no introduction, and we have his recorded session. So over to the ICOG team to play his recorded session.
A very good evening to all of you. It's indeed a pleasure for me to be associated once again with this course and to speak on a very controversial topic where we have a lot of opinions for and against. So it's like rather a debate. And as you can see, the New York Times and all the other magazines have carried this story a long back and many times. Is she just too old for all this? And that is what we are going to talk. I've been asked to take the cutoff age at 40, but I think it should be increased to 45 because at 40 people women can have children. And that is exactly what I'm going to try to discuss in this. No scientific, I'm going to talk more on the psychological, social, financial, and the legal aspects of this. So let's see how important it is for a woman to have a child at any age. I mean, that is the main thing about women, motherhood. Should they go for motherhood even at older age? Well, some people will argue yes, because when we look back at the Biblic times, even God agreed that we must multiply. So God created man in his own image, and God created him a male and female. And then God blessed them, and God told them, be fruitful, multiply, replenish the earth, and subdue it. Genesis 1.2728. Let's then go to Wikipedia and look for the definition of menopause. Menopause is defined as cessation of woman's reproductive ability, the opposite of menarche, and it usually occurs as a national change, and it typically occurs in a woman in midlife during the late 40s and the early 50s. That is why instead of 40, we're going to talk more about late 40s, signaling that this is an end to the fertile phase of the woman's life. Then God designed women to be special. The human body has an organic deadline, which is known as menopause, women, which occurs around late 40s to 50s. After 40 to 54, the baby making naturally may not be possible for a lot of people. Why not should we respect this? God has designed women special, as we know. In the 40s and the 50s, women take stock of their life, get reflective, move to another phase, not so defined by the drama and personal drive of getting pregnant. So that part of the thought is out at this age. God has defined women as special, and choosing to have children after 40 to the 50s or even later, as you can see in this picture, where this woman had a child in the 60s and the 70s, it disrupts the natural trajectory, causing needless suffering, disharmony to both the parents and the child. And I believe it is irresponsible to attempt pregnancies after menopause in late 50s. God has designed women special. How many of you over 40 can run a marathon of 20 kilometers, one or two? And just after the marathon, which ends with menopause or your marathon of life, how many of you will run a 100 meters race after this marathon? Nobody, or maybe very rare one. So that is what life is. Why is there a debate about this? Pregnancies among older women will always remain a controversy and a debate. Some people like me will argue against motherhood in late 50s, in late life, and because it involves a lot of health risk, and we have concern for older women. She might not be around to take care of the child when she ages, while others, some people who do it for records and things like that, and just to prove that science can do everything, they are only concerned about getting her pregnant even if she dies. And that is the tragedy of this. That is the tragedy where these people who are attempting late age pregnancies are playing God and using science, the arrogant misuse of science and playing God. Now, the society has problems with elderly women, and here are some of the elderly women which you can see of the world. The society blames us, the ART specialists. You have gotten used to playing God. In 2006, Carmen Bauset in Spain, now dead, made headlines of becoming the world's oldest mother. She gave birth to twins conceived with IVF. 2 years later, our own Indian Rajyo Devi of India took the record from her and gave birth to a girl child at 70, maybe 72. She is also no longer there. And then these made headlines all over the world. The world's oldest new mom dying after IVF pregnancy at 72, too old to be young, BBC, Fox News, Times, Indian News, everyone covered it. How many people know that Rajyo Devi and her baby nearly died after delivery? and she and her baby were in the ICU for over 2 months, and just 2 or 3 years later, the mother died. There is more to it. Rajadovi may have lived 100 years, but will she be able to provide the kind of parenthood which is desirable? Children today require physical, mental, financial, psychological support. While will she and her husband be able to do that? Alas, that did not happen. What will these triplets do at the age? Now, brought up by a motherless Bateri Devi, who delivered a triplet again in India, just to make records by an ART specialist at 70, they will never laugh like normal children because they have known to take care of them. These are some of the world's oldest mothers. Almost all have died, leaving children behind between the age of 2 to 10 years. And a lot of them are from India, which is a tragedy. There's some from Spain and the other countries also. So the compromise at this age of getting pregnant is that obesity is there in 1 in 5, diabetes is there in 1 in 3, hypertension is there in 1 in 4, cardiovascular diseases, neuro diseases, joints are bad, eyesight is bad, breast and reproductive system has got old, and that there is a memory loss. All these are going to affect this old age mother. Now, if death isn't so scary or for the realities of old age, what if the inevitable caretaking role reversal happens when the child is in high school? If that mother has lived till high school, it seems very unfair that the child is going to be a walking stick to this mother who is hardly able to do anything on her own. So there's a critical decisions. The first is the health issue. Does a woman in front of you have any physical ability to carry the pregnancy successfully because of her cardiovascular, diabetes, and the others, which could see her drop dead during pregnancy or after pregnancy? Do you have the capability and the nerves to take her through this at her own risk and at your risk? Is the question I will ask the ART specialists. The second was a very ethical issue of what is the best in the interest of the child. So there is a very, very thin, slippery line between morals and ethical issues in this. The ethical issues are offering fertility services to postmenopausal women rest with the individual physician of the clinic. Some clinics have adopted their own ethics and guidelines and govern access to the assisted reproduction in postmenopausal women. There are social factors. Older women are unable to take care of these children because they're conceiving in the late 50s or 60s, and these mothers will usually leave their children orphan in the age between 2 to 10 years. And that will lead to these children going haywire with stress, depression, drug use, and it. The reason people couch their objections to the older parents' concern for children make impolitic uneasiness of the parent themselves. Old people should know that they are old and not try to be young by having babies at all. We may talk of reproductive freedom, equality, fulfilling a lifelong dream, powerful need, women fertility, but that is all for talks. Baby lust has seemed to grow so much, and the clinicians have started playing God. Why is the law silent on the issue of age and fertility? Nor does it appear in all the countries, nor there is sufficient justification to enact some age limits. IVF laws on age limits in the world and India are as follows, as you can see. There is a global snapshot to the age, and the common patterns women often limit between 42 to 50. And several countries have set jurisdiction of not allowing pregnancy after 42 in a woman. The funding bodies don't give funds to this legal limit. In America, there is no federal cap on the states and the clinics. The UK NHS funding caps at 42. No absolute statutory age limit for private IVF. In France, there are some specific statutory age ceilings for the use of gametes and embryos. France uses gametes and embryos up to 45, UK up to 42, United States no limit, Australia, the jurisdictional ART Example, in Queensland Act, regulate differently in various states. Practical clinics limit often differ from legal caps, and many clinics set their own cap at 42, 45, 50, even 60, and now in India, as this clinic did, at 72 or 70. The HEFA, the Human Fertilization Embryology Authority, did make some guidelines and licenses, and according to the Human Fertilization Embryology, the NHS funded fertility treatment caps at 38 and 39, and in Wales at 42. So these are the guidelines. What about India? Now, we had no law till 2021. The law was made in 2021 as the ART Act and the Surrogacy Act, and now it has been implemented all over the states. So this law says that the age of donors should be male donors 21 to 55, female donors 23 to 35, and donating only once. For recipients, the guidelines and rules have been interpreted and set the practical upper age commonly to 50 for women and 55 for men. But the legal text and the implication involve regulatory boards and sometimes even a judicial review. The recent Indian judicial development in 24-25, where some couples went to the court for allowing them, the Telangana High Court allowed a 49-year-old woman an urgent access to fertility procedure as she was nearing her 50th birthday, and she would not be able to get it after 50. And the court may show some grant in relief. The Calcutta High Court allowed a 61-year-old man to pursue IVF with his 49-year-old wife, despite the ART donor age related norms and the act. And this demonstrates that how judiciary can be discreet and provide some case-by-case reliefs. Now, these cases highlights tensions between statutory and regulatory age ceilings, individual reproductive rights. We should apply the adoption rules here, and that is the couple's age combined should be 99-90 or less. 45-45 makes it 90. Now, adoption is ready-made child, and the mother doesn't have to risk her child. So we should make the adoption law a little more flexible and easier so that these parents who have not been able to have their own children can adopt easily. Now, the opponents would say that why argue they are just a handful of women? How many children are born like this will either have one parent or there is no statistics. And this cannot be argued that these are just a handful. But these handful all have lost their lives. The mothers have lost their lives. That is what is more important than just saying that a handful of them. Now, these are the figures for 45. You see the maternal age at 25, 30, 35, 40, 45. The risk of mother not surviving till the 18th birthday is about 5.5% with 45 or only 1% with 25. So younger the mother, she survives till the child comes into adulthood. Similarly, the parental age at childbirth, the risk of father not surviving the 18th birthday is 12% if it is 45. So that makes this child an orphan of at least one parent. We all know the health issues. I am not going to talk about stimulation protocols or how the IVF is going to be done in these older women, but we must talk about the antenatal care and the pregnancy problems which these mothers will have. Pregnancy will pose a greater risk. There'll be a lot of medical complications which will be very serious, like cardiac disease, hypertension, PIH, diabetes, placental abruption, all that antepartum hemorrhage, and admissions to ICU. Women over 40 will also pose risk to the fetus, low birth weight, preterm fetal mortality, usual risk of IVF, like multiple children apply here also. And there may be sound medical reason to refuse IVF to the patients in these situations. The ethical concerns we've already mentioned. There is age, there is equity, there is age limits, and there is a legal certainty versus reproductive autonomy, which is to be debated. The practical implications for clinics in India and globally is that please maintain a clear written clinical policy. Document informed consent, emphasizing on the age-related risk, success possibilities, need of donor eggs, adoption. have a legal review pathway for cases near the statutory cutoff, like 49. Court sometimes will grant an interim relief. Follow the donor age verification and record keeping requirements strictly, and monitor everyone. Even if the parent lives long enough, parenting is a big issue with these old parents. Children may experience isolation and stigma because cannot relate to someone who's 60. These parents cannot play. Plus their retirement, so their income is down and they're there. This mother had arthritis and could not do the daily chores of bathing the child, changing nappies and all. So they had to keep nannies, and they had to be, the child was practically brought up out by nannies. The health of this woman also is going to be compromised, and you're just alive. You're not healthy and vibrant, and a child needs a vibrant parent. The paternal age also, though the sperms can be produced, but the semen abnormalities will increase with the age. A man's age is adverse to the pregnancy outcome. Miscarriages, fetal deaths may occur. Father's age at birth or the offspring, probability of adverse birth may be there. Autism, spectrum disorders, bipolar disorders, Down syndrome, schizophrenia, all these are also related to the paternal or the father's age. Now, thanks to the handful publicity seeking Hollywood, Bollywood stars, and to our own publicity seeking ART specialists, the middle-age pregnancy phenomena has been hitting the headlines recently among all the fun and fair. I am sure the pregnancy over 40, 45, or 50 is not acceptable to any one of you who is listening to this, and we need to take care of this menopausal woman rather than trying to make mothers out of grandmother. I agree that there is a goal of every couple is getting a child, a biological child, but there has to be a right time, a right age, not a compromising the life of the mother or the child. Have one, adopt one could be a policy which could be given to these over 50 if they've had one and they're planning for it. I'm sure all of you in the audience who are listening to me would see live mothers, healthy babies, and not dead mothers and orphan babies and record making doctors. Life expectancy, as you know, is increasing, and getting pregnant after 40 means that you will produce a child who will not have a mother or a father. Is that acceptable to you? I am sure no. These are the country's health expenditures. Infertility treatment has no cover. The insurance will not cover. The medical insurance will cancel if you get pregnant later on, and all these old age homes are not there, orphanages. It's a lot of problem. So do you all agree with what I have to say? My argument is I didn't have any grandchildren, so I decided to make my own. And there would be a world record in making. This was an ART specialist from India talking. There was a world record, so I did it. Thank you very much. I did it. And I produced a child in a 72-year-old. Absolutely unacceptable. The RCOG says 42. The Indian says 50, but with permission and with health checkups. The policymakers clarify the recipient age. The clinician should adopt the age-based cutoffs, and for patients should seek timely fertility treatment so they do not cross the age limit. Lastly, God himself wrote, Horace, of various threats, thou art anxiously inquisitive to know, that we are always wanting to know. But God has widely hid from the human sight the dark decrees or the future fate, and sown their seeds in the depth of night. He, God, He laughs at all the giddy turns of state when mortals like you and me search too soon and fear too late. The choice is yours, playing God or not playing God and making healthy mothers. There are lots of references which you can go through and read on all these older age women. Thank you very much, ladies and gentlemen, for inviting me to this masterclass, and I hope I have done some justice on bringing out a different aspect of pregnancies in older age women. Thank you.
Hello. So we will convey our thanks to Dr. Narendra Malhotra sir for his excellent rendition. And can we have Dr. Nivedita Datta for her comments on this session? A quick few words, and then we move on to the last last talk of the session. Dr. Niharika?
Yes, Dr. Reshmi. I think sir brought out a very different viewpoint of pregnancies after 40. I think we are seeing I mean, at least I am seeing a couple of pregnancies after 40, sometimes even spontaneous conceptions. So these are women with a lot of complications, as sir rightly pointed out. And I think the onus is on us that we teach all the patients who come to us about planning pregnancy early, about egg freezing, about the complications that occur. And I think this is all we need to do as gynecologists instead of focusing only on getting them pregnant. I think we have a more social responsibility to prevent more morbidity in women after 40. Thank you so much.
Yeah, so preconception counseling is equally important for teenage and elderly pregnancies. So moving on to the next talk, we have Dr. Naina Patel, who is the ART Queen of India. And looking forward to ma'am's talk. Can we have a CV?
Till you display the CV, Reshmi, let me share. She has just traveled back and she's ready to deliver her talk here. Thank you so much, madam, for that.
So we'll, she will, looking forward to listening to Naina ma'am on ovarian rejuvenation.
Okay, fine. Share.
So as displayed in the CV, she is the medical director of Akanksha Hospital Research Center located in Anand City of Gujarat. And she's a pioneer in the field of IVF and surrogacy. And since she's almost our next door neighbor, I know the way of success in her for her IVF practice and the way she takes care of the surrogates. It is something that everybody should come and see. People talk of ideal menopause clinics, ideal old age homes. But I think we should visit her to Anand to see the way that surrogates are. She has a special home, special facilities to keep them diet, the Garb Sanskar, everything. I mean, it's awesome. I've not had an opportunity to see it, but I've seen pictures and I've heard about it. So over to Naina ma'am. Hello.
Yes, thank you, Dr. Reshmi, for this introduction. And thanks, first of all, Dr. Archana and Dr. Reshmi, ICOG and Foxy. Yes, I'm a part of Baroda with Sushma Ben and everyone. Like, I feel a family when I'm in Baroda. So we are talking about the ovarian rejuvenation, which is a controversial topic, but it is very close to me. And if rightly done for the right selection of the patient at the right time, it definitely brings good results. All the couples want a child with their own eggs. They are not ready to go for donor eggs, and it's understandable. So, is this a high ovarian rejuvenation or a hope? Let us see. This is a young patient which I'm starting, 23 years, husband had testicular cancer, everything done. Then they come to us. We had frozen the semen sample, which were occasional motile sperms. When they came to us, the female's AMH was 0.42. First IVF cycle, plain with him, 6 oocytes, 3 embryo formed, not good quality, negative. After that, we explained about PRP and stem cells. She went for it. And then in May, after 3 months, we did the cycle. In the first blastocyst transfer, she has conceived as an ongoing pregnancy. So rejuvenation means we have to a process by which we replace the damaged tissues with specialized cells. It could be done with PRP, bone marrow, or in vitro activation, which Dr. Sushma Ben has touched. We know that all this time we thought there is a fixed primordial pool, but now we know that there are some stem cells, ovarian cells, oogonias, even at the menopause, there are about 1,000 cells. And folliculogenesis, we know it's a very important part of the human female system and the maturation of the eggs. So it is not only for POI or diminished ovarian reserve, for reversal of menopause. I had patients who had come, fertilization failure, even post chemotherapy you can start, or when the success rate of IVF is low because of the eggs there, but low quality eggs. We know that it releases a lot of factors which are growth factors, and these growth factors will then go to the injured site, that is the low AMH, the eggs in the cortex, and there it will start releasing the growth factors and will rejuvenate the oocytes. The procedure, everybody can do it. I'm very sure you need this centrifuge machine, you need this ACDA solution, and this is the process. You do it properly, you activate it properly, either by the physical activation of freeze thaw, or by chemical, by calcium chloride, and then you have this beautiful paper which will teach you what is the quality of the product. Please check that the PRP, that the platelet count has gone 3 to 4 times higher. We want 9 lakh, 10 lakh. Select the patient properly and it will definitely give results. There are a number of papers which are showing that platelet rich plasma helps. And there are certain papers which even oppose, because there was one fatal complication which has occurred after this, an abscess formation. So the procedure has to be done very, very precisely. And our own publication in the International Journal of Aspire Fertility and Reproduction of 45 patients, which we did in the beginning, out of which 27 conceived, 8 naturally. We are seeing a lot of natural pregnancies, IUI and IVF pregnancy. And this paper is already there in the Aspire site. How do you do it? We have to select the patients. We do a karyotype when we see a diminished ovarian, a premature ovarian failure especially. We go up to 45 years of age also. We have to rule out autoimmune disease, though now we have started doing for autoimmune disease, telling the patient the effect will be very short-lived. Normally it is up to 18 months, but it could be 3-4 months. You should rule out major problems. And when to plan for ovarian rejuvenation. You don't go at the first low AMH, okay, we need to do your ovarian rejuvenation, or 40 years we do it. Past history, you see, if the patient has undergone IVF, repeated failures, low quality eggs, or first time she comes, you can start a plain treatment also. At 40 years also, you can start ovarian stimulation, IUI, and then send for IVF. And if the egg is not good, we go for rejuvenation.
Good evening.
So the patient selection is not that you see low AMH
हा
and
एक वेबिनार चालू છે અડધો કલાક હું પતી જશે.
decide the dosage what you need to give, depending on the size of the ovary, how many platelets you will be giving it. Transvaginally or laparoscopy, depending on if you have to do a laparoscopy, ovaries are inaccessible, very streak ovaries, or you are doing some fibroid removal, you can do it. Precautions are that the patient should be properly prepared for it. You have to be worried about the complications, like the ovaries get adherent to the uterus after that, making it even more difficult. You should maintain the aseptic septic precautions. And also you should see you do not overshoot and go to the ovarian artery. Prognostic factors. So here comes the role of counseling. Which are your good patients? Younger the age, less than 40 better, but you can go up to 45, telling very well that this is the chance of conception. At 45 drops to less than 2%. If the patient had, even at 40 years, a past pregnancy, and now she is not conceiving because of low MH, she will have very good chance, because it is a proven fertile egg and sperm. Then the size of the ovary also matters. A very small ovary where you hardly see anything, it will not give a good result. Finally, the FSH and the AMH. FSH is the first thing which will come down. So very high FSH, but AMH is still, you can still go ahead. But very, very low AMH, you have to counsel. With a very high FSH, you have to counsel that this may not give you good result. But still, if you want, we do it. We do it transvaginally and laparoscopically. It is like an egg retrieval procedure only. And where you just, because this any gynec can now do it, you have to take that egg retrieval needle, go to the ovary and put it in the cortex drop by drop. And 30 seconds or 60 seconds you wait after injecting 0.4 ml. Normally it is 2 ml on both the sides. Laparoscopically, this is now what we have started, holding the ovary, and we blanket the cortex properly so that there is no leakage of the PRP solution or the stem cells. What are you again? Two, hilar and anti-hilar area, we do the punctures. I prefer laparoscopically because that gives a better result. But if the patient has undergone laparoscopy and doesn't want to do it, TVS also had good results. This was my first case. Again, I'll say 41-year-old PRP, which was done in 2015. 0.54, she had number of failed cycles. We did this, and I think 2-3 retrievals, and she gave a good day 3 embryo and a healthy delivery. These are young patients, which I will skip. And this patient of ovarian failure referred by an endocrinologist for donor egg, and we did this, and she conceived naturally. 34 years, the fertilization failure, 2 PNRS, male factor, everything normal, but it was the egg which was bad, and that's why they did the PRP. Stem cells are very promisable in infertility because it has multidirectional differentiation, angiogenesis, immune regulation, and paracry. You can see the oogonia, or the small in the cortex, the oocytes which are there, which are dormant, and we need to activate them. And we have a concept of ovarian stem cell niche. And ovarian stem cell nest is one of the major component which is composed of all this, and this is what we need to stimulate. And this ovarian niche, as it has been found out, is very helpful in regeneration of the stem cells. Mesenchymal stem cells have been used. Normally, we use bone marrow derived stem cells. Adipose can also be used because of its immunomodulatory effect, antifibrotic, and the granulosa cell. There is reduction of apoptosis and atresia, regulation of pro-apoptotic proteins. So these granulosa cells are very, very important for a good oocyte and folliculogenesis, and that is where it helps. And of course, angiogenesis. Adult stem cells is multipotent that we are using. We do not use the embryonic, which are totipotent. And this is the pre-workup, because once the patient, for stem cells, we have to have certain guidelines. You have to give oxidation of the patient, like giving O2 for 2 to 4 liters for 30 minutes, antibiotic, vitamin C. Glutathione is also given, and from the anterior iliac crest or the posterior iliac crest, you get it with this needle, the bone marrow biopsy needle. We attach a Luer-Lux syringe and get out at least 80 ml is good, but up to 30 to 40 is also good. You can take out. Older the female, I would prefer stem cells rather than PRP. These automated units are available with a bag where you collect it and automated it separated. Each sample of the stem cell, you have to preserve a drop. There are no guidelines, but you have to keep it. You have to do the infectious disease profile also on it. And this is a very good paper from Sonia Harayas, where they have seen this, and they have seen improvement in AFC in 2 weeks. And they call it with 2 consecutive increase in AMH. Every 3 months, we assess the hormones, especially the FSH and the AMH. And ovarian function improved in 81. And that was one paper which also inspired us to go ahead more with this. There are a number of papers supporting it, and there are papers which are opposing this also. This female, FSH 14.09, and she had tried for 4 years. Yes, we did this, and she conceived. 33 years with 35 BMI and 0.49. She was also trying. We did this, and in the first IVF cycle, she conceived. And here this patient had a drastic fall in AMH. She had conceived before, so she was a very good candidate. PRP did not help. We went for bone marrow, and she had a healthy child. And this is 39-year-old female. She had 11 IUI failed, 3 IVF failed, 0.862. So again, you don't go to do the treatment. This is the patient who will definitely benefit from bone marrow derived stem cell. In second IVF, she conceived and delivered a healthy baby boy. Even when there are recurrent pregnancy loss in younger patients as well as older patients, you have to think PGTI is, yes, important for older patients, but younger patients and older patients together, we did this analysis, and we found that out of 51, 27 conceived because they had no other reason for recurrent pregnancy loss except for low AMH, and the results were really good. Positive 27, 24 delivered, 3 miscarriages. This patient had 2 failed IVF. She had conceived naturally twice, but there were miscarriages. 0.32 AMH, and as suggested, when 2 IVF failed, that go for donor egg, she came to us. We did this laparoscopic ovarian rejuvenation with bone marrow derived stem cells, and she conceived naturally and had a C-section. And this patient from US, as I said, 46, I just denied her. She said that I'm taking the responsibility, but I want to do it. She had 4 natural conceptions, all miscarriage, including 1 Down syndrome, 1 failed IUI, 1 failed IVF in the US. On her insistence, we went for the bone marrow derived stem cells, EVA technique, in vitro activation, as well as ovarian rejuvenation with PRP also. We combine bone marrow stem cells. When you culture it for 1 hour also on a PRP, they become very potent. So now we combine both this. She conceived naturally and she delivered a baby boy. So at 46 also, as I said, if they have a previous proven fertility, the results are very good. Endometriosis, now we are doing more and more, because it is said that stem cell therapy for the restoration of fertility in patients, it's an inflammatory condition. And we want to reduce the inflammation. Stem cells and PRP are anti-inflammatory. 37-year-old, 2 miscarriages, 0.15 AMH. All we did was PRP rejuvenation, conceived naturally and delivered. So I'm not showing this in detail, but after cleaning up totally, when you are about to finish and the reconstruction is done, that is the time you will inject the stem cells. And people are worried that when you put stem cells in an infected ovary because you have removed chocolate cysts, no. You do proper cleaning, proper antibiotic coverage in the healthy cortical area, which I could not show it to you. But if you do that, you can really get good results. And this patient conceived with the first IVF itself. She was from Himachal, and they had said that you have to go for donor eggs because in your first IVF, the oocytes were very bad. She wanted her own eggs and she came to us. In PCOS also, it is an inflammatory condition. And here also the rejuvenation helps. And this is the latest publication now in 2024 SERM, where they have showed that hormonal balance, follicle development, antioxidant and anti-apoptotic effects of the stem cells in the management of PCOS. In vitro activation, that is the disruption of hyposignaling, just 1 minute more, as Dr. Sushma said, that you have to remove the cortex, cut it into small pieces with the infant feeding tube. We instill it in the same setting only, same laparoscopy procedure. There is no chemical treatment required. While the laparoscopy is going on, when the tissue is sent in the lab, it is cut into small pieces, and then beneath the cortex, now we install in the opposite ovary, or you can put it in the mesosalpinx, and the results are encouraging, but it is definitely an experimental procedure. Professor Kawamura was there at our clinic, and we did some cases with him, and now we have done almost 50 plus cases, and this is the first publication of drug-free in vitro activation baby of India, which was from our center. Exosomes are the new kid on the block. Looks promising, but you cannot combine exosome and stem cell. It has to be either exosome alone with PRP or stem cell alone with PRP. And finally, for a stem cell therapy, these are all the certifications you will need. A CDSCO certificate is very, very important because they consider it as drug. And this, everybody is welcome to see the stem cell lab at Akanksha Hospital. And with this, I conclude that stem cells and PRP play a major role in regenerative medicine. Yes, controversial, but you have to do it in the right way. Otherwise, any treatment you just start. There are people who get the PRP from the pathology lab. The patient is sitting with that PRP for 3 hours. What will be the potency? They are most potent PRP within 15 minutes of activation. Either you put it in liquid nitrogen, bring it out, liquid nitrogen, again bring it out, or calcium chloride. And that time the patient should be ready in the OT, because in 15 minutes the granules will break and all the growth factors will come out. If you do it after 1 hour, there is no result, and people say PRP is not giving any result. So please read that paper on the quality, how you prepare PRP, and do it yourself, and you will really be satisfied at the end of the day. Yes, it does not help all the patients, but in indicated cases with proper selection, proper technology, the patients can be hopeful of getting their own oocytes to have their baby. And with this, I thank once again everyone, Archana, Reshmi, for giving me this opportunity. Have a good.
Thank you, ma'am, for
ISTA
this.
2026. Well, inviting all.
Yeah. So thank you so much, ma'am. It was excellent. Means my mouth was continuously open. How you have developed so many new things, just a 15-minute talk, and we were talking about what not. Thank you so much, ma'am. And Niharika, you are the one who's going to wrap up this also. I would like to hear some Bakshi ma'am also, a one-liner, something if she wants to add.
Thank you, Dr. Archana. Dr. Naina, I think that was a wonderful talk indeed, and you took us through your journey. And we hear a lot about PRP. I would want to tell all the delegates that a lot of them hear about PRP, and like you rightly said, they start experimenting in their own clinics. I think they really need to know the right technology, how to do it, right training, and right knowledge of what to do before they start doing it. I see a lot of small setups doing PRPs without any idea of what they're getting into. So I think it's very important that they're very well aware of how things are to be done firstly. And as you rightly pointed out, they shouldn't be done for everybody. The patient selection is, I think, very, very important.
Yes.
And these are all newer things on the block. And I'm sure we're going to have more and more things in the future with people planning pregnancies later and later. So very well done, ma'am. Thank you so much.
Thank you, everyone.
Thank you, Dr. Rachna, for giving me the whole session to chair.
Thank you, dear. You are so clear. You were an asset to us for the today's this thing. Thank you so much. Bakshi ma'am, would you like to say something? And
Yeah, certainly.
I would
Yeah, this is really a nice capsule in which all the ingredients are filled very wisely and really informative. The entire today's session you have done. I am very happy about it. And I agree with Dr. Naina that there are so many procedures, so many newer procedures, and innovations are going on. But judicious use of it in favor of patient is going to help all of us and to the patients also. So, I mean, that part should remain with us, that the judicious use is the best thing we should follow.
Thank you.
please wait out 5 minutes. Thank
So
you.
now-
Thank you. Yes, Rashmi, you will do.
So now I think, can we have, I think all the questions have been answered by the speakers in the chat box. If not, the speakers may do so, because I don't think so we have much time for question answer session. And Nilima, how will be providing the post test form questionnaire Google form? You will be putting the link in the chat box, right, Archana?
Yes, I think the team will do that. Chat box, the link. Nilima, please, Gauri. Yeah, they are doing it. And 15 minutes is the time which is allotted. So everybody please go through that. And once the 15 minutes is up, you can submit whenever you are done with. Thank you.
आप कंप्यूटर नीचे रखो मैं यहाँ पे करूँगी तो खाने के टाइम पे तो काम करेंगे
I think maximum people have finished their test.
Approximately 4.5 minutes remaining.
Yeah, we have to give, technically we have to give that.
No, I know that, but there's a message in the chat box to give reminders.
Mm-hmm. Kera लीजिए तो consulting. एक second. I think maximum people are asking for question number 16. Please attend. Don't worry. We'll take care of whatever the answer is. We'll display the answers will be read out by Dr. Reshmi shortly. Just wait. After say 3.5 minutes. So just wait for the answers.
हेलो मैम, मैंने आंसर शो किए हैं.
Yeah. So the time is over, I guess.
Reshmi,
Yes,
you
ma'am.
can just read out the answers.
Okay. So the most important factor affecting fertility is age. Then social freezing is done for any of the reasons above, for any of the reasons except cancer. So for cancer, the others are social freezing. Then which potential benefit is also application PRP for ovarian rejuvenation is, yeah. So each potential benefit associated application of PRP ovarian rejuvenation is enhancement ovarian functionality and increased blood circulation. NCD screening is ineffective false. You can reduce incidence of NCD by effective screening. So what is the definition of premature menopause? Menopause that occurs before the age of 40. Which of the following is a primary hormonal marker for diagnosis of POI is elevated levels of FSH. Can we go up? So premature menopause associated with increased risk of cardiovascular disease and osteoporosis. Next. Which of the following is a common treatment for premature menopause? That is hormone replacement therapy. And which of the following is the most accurate marker of ovarian reserve in women above 40 undergoing IVF is AMH. Then according to the Indian ART and current ICMR guidelines, what is the maximum age limit for women to undergo ART treatment, including a donor oocyte cycle? It is 50 years. So which of the following is not a common symptom of vasomotor syndrome of menopause? It is weight gain. Then which antidepressant approved for treatment of VMS should be avoided in women taking tamoxifen? It is, let's scroll up. It is paroxetine. In which of the following associate considered a key component of good sleep hygiene? It is maintaining a regular sleep-wake schedule. Next. For how many hours of sleep is generally recommended is 7 to 9 hours. Which habit negatively affects melatonin production and delays sleep onset? It is exposure to bright screens close to bedtime. And menopause is retrospective diagnosis of amenorrhea of 12 months. Then pelvic floor muscle becomes weak due to following except vomiting. Kegels exercise is done to prevent all of the options. Then sexual dysfunction due to pelvic floor weakness causes anorgasmia in females, all of the above. AI can be used in menopause management. In which of the following scenario it is all of the above? Done with the questions?
Yeah. So thank you, Reshmi. Thank you, everybody. I think people are very happy with the scores. I can see 19 by 20 and all. So that's a good thing. I think all the stalwarts made it very clear. So we are now on the last part of this evening where we had earned some knowledge, which will be adding to the wisdom which we are going to practice day to day in midlife patients. So just to deliver the vote of thanks, I'm very happy to be a part of this academic platform. Thank you, team ICOG, Dr. Parag Binniwale sir, Dr. Sarita Bhalerao madam, Dr. Ashok sir, Dr. Sheila Mane madam for this excellent opportunity. And also Foxy President Dr. Sunita Tandulwarkar madam, our Secretary General Dr. Suvarna Khadilkar madam, our co-conveners Dr. Anju Soni madam, Dr. Rajendra Nagarkatti, my coordinators Dr. Reshmi, Dr. Madhumita, Dr. Aditi Rathod, and the stalwarts who made this possible, Dr. Maninder Ahuja madam, Dr. Shaijas, Dr. Pankaj Desai sir, Dr. Manju Verma ma'am, Dr. Narendra Malhotra sir, Dr. Naina Patel ma'am, Dr. Anita Shah ma'am, Dr. Padmini Prasad ma'am, Dr. Bakshi ma'am, Dr. Naina Patel ma'am, and our chairpersons, Dr. Vandana Patel ma'am, Dr. Pratibha Singh ma'am, Dr. Aditi Rathod, Dr. Neeraj Jadhav, Dr. Kanchan Sharma ma'am, Dr. Niharika Allu, Dr. Nivedita Datta, Dr. Shubha Shetty. And last but not the least, our team ICOG, Nilima Gauri, you guys have done the fabulous job with all of us together. So I think we are signing off for today. There is some controversy with some question people are putting in the chat box. Definitely, I'll get back to you. So don't bother that. You people have scored well and that question will be under my consideration. Nilima, you can note it down. So tomorrow in the session, we can always declare the proper explanation to them. So thank you, delegates. Thank you, faculties. Thank you, Team ICOG, for making this possible. And I wish you all a good night. Happy knowledging together. Once again, we'll meet at 4 p.m. tomorrow for the second session of this certificate course. Thank you. Good night. Signing off. Thank you, support team. Bye.